Good morning, everyone, and thank you for joining the last session of this advanced imaging lecture series from the Iowa ACC FIT Council. Along with me, I have my FIT co-chair, Vikram, joining me to welcome you to this session. As a reminder, please keep your microphones muted and please put any questions you have in the chat window and it'll be moderated at the end. It's my distinct pleasure to welcome Dr. Milind Desai for a first talk. Dr. Desai is a professor of medicine and radiology at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. And he's also the Haslam Family Endowed Chair in Cardiovascular Medicine. He's also the Director of Clinical Operations of the Robert and Suzanne Tomish Department of Cardiovascular Medicine at the Settle and Arnold Miller Family Heart Vascular and Thoracic Institute at Cleveland Clinic. Dr. Desai is the director of the Center of Hypertrophic Cardiomyopathy, the medical director of the Center of Aortic Diseases, medical director for Center of Radiation Heart Disease, and integral part of the Center for Valvular Heart Disease. He's an expert in multimodality cardiovascular imaging, having achieved the highest level of proficiency in all imaging modalities, including cardiac MRI, cardiac CT, echo, and nuclear cardiology. In addition, he serves on the multiple heart vascular and thoracic institute councils, including executive councils, operations, and research councils. He also serves on the Cleveland Clinic Research Compliance Committee. A native of India, Dr. Desai received his medical degree from NHL Medical College in Ahmedabad, in India. He completed his residency from Southern Illinois University School of Medicine in Springfield, his fellowship in nuclear cardiology from Brigham and Women's Hospital in Boston, cardiology fellowship from Allegheny General Hospital in Pittsburgh, a fellowship in general cardiology and cardiovascular imaging at Hopkins, and a fellowship in cardiac MRI at NIH. He also completed a physician executive MBA at the University of Tennessee. Dr. Desai's research interests include large outcomes studies in valvular heart disease, hypertrophic cardiomyopathy, radiation heart disease, coronary artery disease, and aortic disorders. Is now active in leveraging use of artificial intelligence in imaging and predicting outcomes in various cardiac diseases. It's also leading two multi-center clinical trials in hypertrophic cardiomyopathy and valvular heart disease. Dr. Desai has authored or co-authored numerous articles and book chapters in publications such as JAMA, Lancet, Circulation, JACC, European Heart Journal, Heart, JACC Imaging, Circ Imaging, and JAMA Cardiology. He serves as a reviewer for multiple journals and has served as guest editor for Circ and JACC, and is on the editorial board for JACC Imaging, Circ Imaging, and European Heart Journal Cardiovascular Imaging. Dr. Desai is the past president of the Certification Board of Cardiac CT and is on the board of directors for the Intersocietal Accreditation Council. He also served in multiple committees for ACC, ASC, AHA, and SCCT. He has helped write the international guidelines for transcatheter aortic valve replacement, multimodality imaging, and hypertrophic cardiomyopathy, ARVC, appropriateness criteria for cardiac CT, pacemakers, and ICD. And he has lectured nationally and internationally on various topics related to his specialty interest. When his leisure time, if he gets any leisure time, he enjoys spending time with family, watching sports, tennis, going to the gym, traveling with family. And he says he spends a lot of time focusing on the Cleveland Brown. Milind was also our neighbor when I was in Cleveland. So it gives me a distinct pleasure to see him here talk with us. Thank you, Milind, for doing this. We appreciate your time.
Thank you so much, Mahi, for that kind introduction. Yes, Mahi and Ravi, they were literally our next door neighbors. Just this week, it was announced that one of the other person who lived in the same development as us is now the dean of the Brown Medical School. So that tells me two things. One is I do live in a reasonably good neighborhood. And the other thing, perhaps I need to get the heck out of here to get anything done in life. But anyway, so far I'm here and thank you for the invitation. Well, today we talked about what to talk, and today we are going to talk about role of imaging in TAVR workup. The key word here is, originally I was going to talk about CT, but I'm going to weave the tomographic imaging in the context of patients with transcatheter aortic valve replacement. Here are my disclosures. And so let's start I'm a simple-minded clinician at the end of the day. And let's start with a case. This is a 56-year-old female, seen a few years ago now, severe symptomatic aortic stenosis. Cirrhotic, hepatitis C, MEL score was about 10. Patient has all the bells and whistles that go with this bad diagnosis: portal hypertension, variceal bleed, diabetic. She was turned down for cardiac surgery because of the higher bleeding risk related to cirrhosis. Her STS score was obviously very high. And as seen on the echo images here, there is severe aortic stenosis. Not much argument about that. So this patient underwent, so obviously was referred for TAVR, for transcatheter aortic valve replacement, and underwent a contrast-enhanced chest, abdomen, pelvis CT with various measurements, including the image on the left is that of a multiplanar reformat reconstructed image of the aortic annulus with all kinds of measurements, including area, perimeter, minimum, maximum diameter, etc. The image panels on the right show the amount of calcification that this person had. No prohibitive findings. Otherwise, once we got through all these fancy measurements that we'll talk about, there were no prohibitive findings on CT. Femoral diameter was thought to be around 9 millimeters. Essentially, everything, all sequences were a launch, and the space shuttle was launched off. She proceeded and had a successful Edwards Sapien TAVR. Let's go to this other patient who presented with shortness of breath, 84-year-old female, who was referred for TAVR for severe symptomatic aortic stenosis. Outside echo revealed low flow, low gradient, severe aortic stenosis. And this cardiac MR, I'm not showing the echo because echo did confirm but the cardiac MR here shows a lot of calcification, thick concentric hypertrophy. Our echo did confirm a valve area of 0.7 centimeters square. What was noticed there, again, confirmation was a stroke volume index of 29 cc's per meter square, and a very abnormal strain pattern was reported. This is the MRI as we talked about. For those of you who do multimodality imaging and MRI, this is a late gadolinium enhanced image, which is highly, highly abnormal. There is hyperenhancement, diffuse hyperenhancement of the entire LV, as well as atrial enhancement, interatrial septum. Long story short, this person does not appear normal. This is not your garden variety aortic stenosis. This person had severe cardiac amyloidosis. And so, yes, while this person was referred for TAVR, thinking through this process, this person's symptomatology may or may not be entirely due to aortic stenosis. We certainly need to understand the problems associated with amyloidosis and have a game plan related to that. So the key is you have to be a good clinician, and you have to incorporate multimodality imaging, not just echo, but CT, and maybe in some scenarios, advanced imaging besides that. So talking about tomographic imaging, I have just listed it in the context of transcatheter AVR, how, where, and why we use all this. So prior to the procedure, you may need to define and confirm morphology for which, and again, this is assuming everybody's got a good quality echo, okay? So to look for calcification, CT is emerging as an important modality, calcium scoring on non-contrast CT. To define or confirm morphology, you may typically use echo is good enough, but CT or sometimes CMR may be needed. Annular sizing, mostly with CT now, occasionally TEE and CMR, and we'll talk about that. Peripheral vascular assessment, as well as it is important to recognize that we need to do differential diagnosis and tissue characterization in some cases. A lot of these folks are older, And about 10% of these patients may have concomitant amyloidosis or something along those lines, and we have to be careful about that. There's a huge role for post-procedural assessment. New procedures bring new set of challenges. So leaflet thrombosis is thought to be something that occurs not infrequently in the context of bioprosthetic valve placement. Sometimes it is needed to ascertain where the valve is positioned, and sometimes you may need beyond echo and transesophageal echo cardiac MRI to assess for paravalvular leak. So as it relates to CT imaging, it is not a one-size-fits-all. So you have to really know exactly what you want. If all you are looking for is confirm whether this aortic valve disease is severe or not, the guidelines now recommend doing aortic valve calcium scoring. In fact, in the past, the conversation used to be if you have low flow, low gradient AS, to rule out pseudo-severe versus severe AS, do dobutamine echo. More and more data is now emerging where it does not provide incremental value. And instead of that, more and more people and the guidelines are now resorting to using calcium scoring on non-contrast but gated cardiac CT. If you are looking for a valve assessment only, where you want to understand morphology, then you could consider doing contrast enhanced 4D CT. In this context, most of these patients are older, so you're not necessarily going to look at their coronaries, so you don't need to be giving beta blockers or nitro. Remember, especially if you have somebody with critical aortic stenosis, these drugs can be detrimental. Now, if you are clearly doing something to plan for a procedure, then it is necessary to do a full-on chest, abdomen, pelvis scan to not only look for the aortic valve morphology, but also look for peripheral vasculature. There may be some scenarios, especially in younger patients, where you don't want to send them for a heart cath, somebody with severe bicuspid aortic stenosis. You don't want to send them for a left heart catheterization, but you do still want to understand their coronary anatomy. In that context, you can, in addition to doing what we talked about, you could do a full-on coronary CT protocol, including sub-millimeter slices and judicious use of beta blocker or nitrate. So as I said, it is not a one-size-fits-all. You have to be careful about what you have to really know what you want, what you're looking for, and then tailor everything accordingly. It is important, especially as a CT imager, you need to make the Hounsfield unit your friend. So as all of us know, Hounsfield unit is the density that is measured and routinely reported on CT. So ranging between 0 and 500 or infinity, 500 and beyond, if you're the thrombus, if you are dealing with a thrombus on the valve or within the coronary, it is a low density. It lies in the between 0 and about 100. Myocardium tends to be between 50 and 150. Panus tends to be centered around 130, 150, but it has a standard deviation. So between 90 and 250. Contrast typically hovers around 200 to 300. And calcification is, especially full-blown calcification, tends to have a wide range, but typically more than 250 to 300, and sometimes even greater than that in terms of density. So using this, you can basically help identify, is this thrombus, is this Panus, is this contrast, is this calcification, etc. So just use this as you are working through a case. So let's go through where and how we use this. The first step, typically a well-done echo, or in many cases a transesophageal echo, will ascertain the morphology of the valve to a point where you don't need to reinvent the wheel on a CT scan. But often, because of heavy calcification, echo or TE may or may not be sufficient, and CT more and more is being used to ascertain morphology. So there's 3 scenarios that I am laying out here. The scenario on the left is a patient with clear-cut bicuspid aortic valve stenosis. Bicuspid aortic valve with a partial fusion of the left and right coronary cusp. The center panel shows somebody with a trileaflet aortic valve, but it is heavily calcified. And the panel on the right is a patient who basically has concomitant aortic pathology with a very large sinus of valsalva aneurysm. This human being should not have a TAVR if this person was presenting with aortic stenosis or what have you. This person needs a full-blown open procedure. Sometimes and many times, we end up doing aortic valve planimetry on CT. Basically, the panel on the left shows severely stenotic aortic valve with an area of less than 0.7 centimeters squared. The image on the right, this is a diastolic phase image where you can essentially appreciate that there is a central opening which is consistent with significant aortic insufficiency. So you can effectively measure regurgitant orifice on a well-done CT, a gated post-contrast well-done CT. Aortic valve calcification, you're going to hear more and more about this as the years go by. It has clearly become an important tool, not only to confirm a diagnosis of severe, but also to ascertain prognosis, etc. So there are many patients, and in fact, in my practice in the last year, I have found myself routinely doing this. If the patient has moderate aortic stenosis, or the numbers on echo come across as moderate aortic stenosis, but the patient is more symptomatic than what meets the eye, then two things cross my mind. Does this person have amyloidosis, or are we underappreciating the severity of aortic stenosis? And I've stumbled upon both types of patients when I have investigated further. So typically, nowadays, if I see somebody with moderate severe aortic stenosis and just blaming their shortness of breath on their obesity or diastolic dysfunction, I will go the extra distance of making sure they do not have they do not have a scenario where the echo is underestimating, or certainly we want to make sure there's no amyloidosis. So moving on to, you have decided this human being does not have anything, and this person is ready for consideration for a structural evaluation, a heart team evaluation. So what do we do? So it is important to recognize that unlike open heart surgery, where the surgeon can use a Hagar dilator and can ascertain the size of the annulus as well as the valve plane, here in TAVR, we are doing it blinded. We have to exquisitely rely on imaging. Now, the problem with our current reliance on only echocardiography is what? It is only a two-dimensional assessment, typically, unless you do 3D. But remember, 3D is only as good as a good quality 2D. It is absolutely important to have a 3D annular assessment for valve size. And using only a diameter, it is clear diameter does not take into account the possibility that the annulus could be elliptical and not circular. And in that situation, you may be grossly over or underestimating. The image on the left also shows, depending upon where you put your measurement on a 2D, you may be off by a few millimeters. And here, you don't want to be. You definitely do not want to be off by a few millimeters, or even worse, because there are implications as it relates to oversizing, undersizing, as well as paravalvular leaks. So you need to be absolutely precise. So yes, 3D echo, 3D TE can be good, but that's semi-invasive, and CT is much more accurate. So this is, it is important, cannot underscore the importance of multiplanar reformatting and precise measurement of not only the minimum and maximum diameter, ascertaining that it is not elliptical and it is indeed circular, report the perimeter, as well as report the area. Now the CT today is the gold standard for doing it, but as I've shown in the panel on the bottom left, you can do it on 3D TE. In a pinch case scenario, you have a patient who is allergic to iodine or has renal dysfunction and has esophageal varices and cannot have a TE. We do non-contrast cardiac MRI of the aortic annulus and can get similar information to what you can get on CT. And basically, this helps the interventionalist plan and pick the appropriate size. So this is where CT is the first line, but multimodality imaging can be useful. As I alluded to, CMR can also be used as a substitute in a pinch situation for MDCT. And this is a paper from a few years ago which said, when appropriately done with appropriate gating, etc., annular assessment can be similar to MDCT. At the Cleveland Clinic, what we do is we typically do whole heart non-contrast CMR. So we are not giving gadolinium in this situation. These are navigator-gated whole heart non-contrast scans. And of course, if you want to measure aortic calcification, right now, the standard way of doing it is non-contrast CT. There is techniques being developed and research is coming out where you can measure calcium scoring on contrast enhanced CT, but more data to emerge. But suffice to say, using multiplanar reformatting, you can ascertain the severity of calcification. Sometimes what ends up happening is we see a patient where there's not much calcium, the gradients on echo are low, yet because of wrong measurements on echo, the calculated aortic valve area is reportedly on the low side or is on the severe side. So in that situation, CT often helps clarify the scenario and confirm that this is indeed not severe aortic stenosis. Another important thing is the panel on the bottom left is to understand the degree of calcification in the annulus. You can imagine trying to open a valve with calcification that looks like the third image on the panel with severe annular calcification. You may rupture the annulus trying to push the envelope. So it is absolutely important to be aware of this. Another important thing, especially in patients with native coronaries, is to understand the precise distance between the aortic annulus and where the coronaries take off. Depending upon which transcatheter valve you use, this may be important. The last thing you want to do is have an occluded left main in the middle of a procedure. So what ends up happening is if the leaflet length is long, you can imagine the valve pushing the leaflet towards against the ostium of the coronary arteries, and now you have a slight situation in your hands. So typically the interventionalists get uncomfortable when the height is less than 1 millimeter in these situations. Another thing, this is work done by Dr. Schoenhagen, whom you will be hearing from in a few minutes, where you can utilize CT to predict angiographic planes so that the interventionalist is not fumbling around trying to find the ideal plane to use when they are implanting the valve. So all these things have become very sophisticated now, and a lot of softwares can do all these things automatically. Another important thing, obviously a crucial thing, is to ascertain the degree of calcification in the iliofemoral vasculature. As you can imagine, the sheets that the stent equipment is deployed tend to be slightly larger than what you would use for left heart catheterization and stenting, coronary stenting. So it is important to understand the size as well as the degree of calcification, because the last thing you want is a misadventure in the pelvis, and now you have to call your friendly vascular surgeon who may or may not be happy about that. So all these things are part of the standard protocol and how we report these scans. Sometimes the story is not in the aorta or the aortic annulus, but outside in the extravascular findings. All these three cases belong to patients who were sent to us for TAVR evaluation. Top left, person with lung cancer. Middle, some nastiness seen in the esophagus, which ended up being esophageal cancer. And clearly this person has very advanced restrictive lung disease. You know, as you can imagine, this person is not going to be a candidate for TAVR, for open surgery, but the only option this human being has is TAVR. But you better make sure when you are doing informed consent that if the TAVR procedure goes south, there is not going to be any surgeon able to bail this person out. So it is important to pay extra attention. And remember, all these patients are much older, so they've been on the planet long enough to develop all these strange pathologies. And as Dr. Schoenhagen will attest to it, sometimes it takes a lot longer to read these than the aortic measurements. Differential diagnosis, obviously, I've shown this example. Amyloidosis is a big player that is emerging, and a lot of practices now, they are incorporating screening for amyloidosis as part of their TAVR workup, because if 10 to 15% patients have amyloidosis, then it is important that we get to know that. And a lot of practices now, as I'm not going to talk about nuclear cardiology, but this technetium pyrophosphate scan, which was originally developed as a bone tracer, is thought to be highly, highly sensitive for TTR type amyloidosis and is now routinely utilized in the context of screening or evaluation for TTR type amyloidosis. So you are done with your TAVR. You feel happy. The interventionalist says life is good. Sometimes life may not be as good as the interventionalists hope for. An important thing that has been recognized since we started doing TAVRs in earnest is this business of hypoattenuated leaflet thrombosis, or HALT. These are patients who have often, now we are recognizing patients after TAVR have slightly elevated gradients and some nonspecific thickening on echo or TEE. You do a CT on these patients, what you see is this low density thickening that is in the range of thrombus as it relates to Hounsfield units. These patients, typically you treat them with anticoagulation. If you repeat the scans, the gradients improve, and certainly the thrombus gets better. So more and more, obviously every lab, every structural team does periodic monitoring of echoes, not just only for symptomatic patients, but for asymptomatic patients. If you see an elevation of gradient, then you have to suspect HALT, and CT is by far the gold standard and very precise to assess for this. Obviously, the other scenario is it a job well done? So these are three cases. One of the panels on the left are balloon expandable and panels on the right are self-expandable. So the panels on the left in the first set of pictures is optimally placed valve. Clearly the middle panels where the valve is not placed optimally and it is a little south of the border, and the panels on the left, on the right, I mean, are slightly higher than my comfort zone. And as you can imagine, looking at the panel E, that stent strut is extremely close to the left main, and it could potentially create a problem. So, and the other scenario, especially now, if you look at panel D in the right images, this is the self-expandable valve. You can imagine that is obviously placed a little south, more south than what I would like for it to be placed. And this is now approaching the pacemaker circuit box, the HIS bundle, and you may end up needing a pacemaker in this context. Valve migration is mercifully not a common scenario, but certainly not something that is not unheard of. So precise CT measurements are good to make the diagnosis clearly. This person, the prosthetic valve has migrated significantly from the annulus, and this is clearly a slight issue. Thankfully, I'm not an interventional cardiologist, but this would call for an interesting day discussing with the family as to what happened and what needs to be done. Patient prosthesis mismatch. This is real. This is happening, and the more sophisticated we get, the better we get at recognizing. This is a patient of mine who, I remember him, this was I think last year or year before, 68-year-old man. He underwent valve-in-valve TAVR 3 months prior. This was in New York for severe prosthetic stenosis. Now he's got significant dyspnea, and the gradients are 61 and 43. We measured the gradients, and so clearly there is concern that there is some patient prosthesis mismatch. We did this CT, which showed that the narrowing was at the valvular level, where the ERO measured at about 16 millimeters. So this is a robust, well-built guy for whom 16 millimeter of effective regurgitant orifice is not going to be enough. This CT has a important role, adjunctive role, where it can show a small effective orifice area, but normal functioning leaflets and no concomitant thrombus or masses on the valve. So in conjunction with echocardiography, it can help provide confirmatory diagnosis. And it is seen with increasing, the more valves we do, the more we are going to see this. Panus. This is another thing. So now that these technologies are going to be around for a long time, you're going to see all kinds of patients. Panus is a fibrous tissue that grows in the periannular region, and it can be up to 4.5%. It is seen equally in mechanical and bioprosthetic valves. Sometimes it gets difficult. Is it Panus? Is it thrombus? Is it endocarditis? A lot of it has to be put in the context of the clinical presentation. This is a paper published a few years ago where you can utilize CT to distinguish between Panus and thrombus. So typically Panus is after 12 months of surgery. Thrombus can occur anytime. Typically Panus is below the prosthesis, whereas the thrombus is above or below the prosthesis. Morphology, it is typically Panus is circular, extending from the sewing ring with a certain amount of contrast enhancement and calcification. As I showed you earlier, attenuation on CT tends to be around 150 or slightly higher. Thrombus generally, not generally, unless it's an old thrombus with concomitant calcification, it is pretty much lower than 100 Hounsfield units. So there's another, obviously, TEE and surface echocardiography would be the gold standards to assess for paravalvular aortic leak. But there is a role for tomographic cardiac magnetic resonance to ascertain or rule in or rule out presence of paravalvular of aortic regurgitation. Obviously, relying on the jet visualization is not the way to go. Here you would do regurgitant fraction calculation using phase contrast echocardiography. Phase contrast CMR, sorry. So what is the routine imaging? Obviously, you do a transthoracic echo. This is in the broad context of bioprosthetic aortic valve. And where does tomography fit in? If you have high risk for complications, then you repeat a TE at 1 month, 3 to 6 months, and yearly. If you have increased thickening of gradients, then you can do TTE, but most of us now would proceed and do a 4D contrast enhanced CT. If you rule out thrombus, then watchful waiting. If you obviously see HALT or thrombus, then you need to treat. Otherwise, if there are no major issues, then you continue with transthoracic echo. At least in our practice, there is no role for routine serial monitoring of TAVR valves using CT scans or MRI. We routinely only use echo. We go to CT only if there is a reason to do so. Now, the more TAVRs we put in, the more these patients are going to come in a decade or so, and we will need to be doing valve-in-valve procedures. So CT undoubtedly will and has a major role in these. Obviously, we would do standard TAVR planning. We need to ascertain the virtual basal ring to coronary distance. Sometimes we may just need to know what the heck type of a valve there was. Stented, stentless, sutureless. There's all kinds of valves. As I alluded to, we have to look at Panus, calcifications, etc. In the context of valve-in-valve, if your coronaries are less than 3 millimeters away, that's high risk. If it is 3 to 6 millimeters, it is intermediate risk. Obviously, more data is going to emerge in this context. So to conclude, in 2022, TAVR has quickly become the first line in treatment of severe AS patients. Because of lack of direct exposure, you need extensive pre-procedural planning, often using multimodality imaging. Aortic root and peripheral vasculature are best assessed on CT, occasionally CMR. You may need differential diagnosis, extra cardiac findings. Do not forget to look for masqueraders and use whatever it takes. It is important to occasionally look for post-procedural leaflet thrombosis as well as Panas, and you may have to go the extra distance to evaluate for paravalvular AR. I think I'll stop here, and I'd be happy to answer any questions. Thank you for the invitation.
Thank you so much, Dr. Desai, for that fantastic lecture. Really enjoyed it. And thank you once again for making time to deliver the lecture this morning. So I'm going to start with the questions we have in the chat. So one question that was posed is that what is your take on discordance between echo and CT valve area? For example, they've given a scenario of somebody who has a valve area of 0.9 on echo with a mean gradient of 45, aortic valve calcium score of 1400, but the CT valve area comes out 1.5, so much bigger. So how do you suggest proceeding in this scenario?
So couple of things. So the numbers don't, this is obviously a hypothetical scenario because, if you have a valve area on echo, so first and foremost, the valve area on echo is derived. It is not measured, number one. Number two, but it becomes less of a story for me, especially if the mean gradient is more than 40, then the other measurements become less of an issue as far as I'm concerned, because this person clearly, especially if they are symptomatic, this person has clearly severe aortic stenosis. Now, me, routinely myself, when I report CTs, and so I report CTs, I read echoes, and I take care of patients with aortic stenosis. So how do I look at in my little brain? I look at the congruence of gradients and valve area on echo. If everything is making sense, then everything is making sense. If everything is not making sense, then I go next to calcium scoring. The least I rely on is valve area measurement on CT. That's simply because it has not really been validated. And to me, the way I think about it is as follows. The valve area cutoffs that people report in guidelines, they're based all on echo. So my expectation, my suspicion is the valve area that you see on echo versus valve area that you measure on CT area will be slightly higher anyways. So you cannot use the same cutoffs. That would be my final say on this.
That's very helpful. Thank you for that. So in your experience, what are the kind of most challenging situations that you come across when we are looking at CT evaluation, like perioperatively in TAVR?
Challenging?
Yes.
Yeah, try reading a CAT scan at 4:30 p.m. on a Friday before the long weekend in a 94-year-old who had prior pancreatic cancer with Whipple's procedure and a hemicolectomy, and now may or may not have lung mets. Yeah, to me, that is the most painful part of a TAVR CT is all the comorbidities that you have to deal with. But that aside, I often joke, reading a CT scan is kind of like getting married. You get your good-looking spouse, but you have to deal with your outlaws. So the extra cardiac findings are like your outlaws. There's no way around them. You have to just, So having said that, in the context of specific TAVR, what is the most challenging is working around artifacts to me. Is if you have, garbage in, garbage out. If you have a motion artifact in the annulus and now you're trying to make precise measurements, that becomes difficult. The other scenario is if you have a lot of annular calcification, then where do you measure? Where do you draw that circle? And there are now automated softwares that can automatically draw circles for you. But let me tell you, my friend, when you have motion artifacts and when you have calcium, automatics don't work. Then artificial intelligence doesn't work. Machine learning does not work. Then humans have to get in on the action. So those, to me, are some of the challenging scenarios.
Great, thanks for sharing that. Let me see. We don't have a lot of other questions here. Let me ask Dr. Ashwath if she has any questions or comments here.
Thank you very much, Milind. That was an amazing review of everything related to TAVR. Really appreciate you doing this. I just had a question about, when you see a patient in the clinic with severe aortic stenosis and you're thinking TAVR, then what is your next step and how do you approach it? The patient just had an echo and let's say the valve was not very well seen, the gradients are probably increased, then how do you evaluate that?
Yeah, so nowadays it's not, you almost assume, given the partner 1, 2, 3, 4, partner 25, all the data, that there is reasonable equipoise in a tri-leaflet heavily calcified aortic valve that I have no problem offering TAVR as a first line, especially if it is isolated AVR, etc. I have no problem offering TAVR as a first line. So my next step in that context, look, and as I've said, if I am not convinced that this is a severe AS, or if I'm not convinced about the severity, the numbers on echo don't jive. So the first and foremost thing I do is I look at every echo myself. If visually it's looking severe and the sonographer has the gradients that are suboptimally reported, or then I'm going to send the patient, or if I'm hearing a murmur, S2 is reduced, and if the murmur is sounding loud, there's something up in the neck, I'm going to go send the patient back to repeat the echo or get gradients. Too often, sonographers only go through standard views, apex, etc. They don't do right sternal border, they don't do suprasternal notch. So you need to make sure the data is accurate, because otherwise garbage in, garbage out. So let's assume the values are still in the moderately severe range. Then at this point of time, I find myself doing more and more aortic valve calcium scoring. Before, we used to do dobutamine echoes. The we published data, it's not helpful. It's a waste of my time and the patient's time and everybody's time. So I would go to calcium score. Let's assume that there is no ambiguity. There is severe AS, physical exam, symptoms, echo confirms. Then I would just go do a TAVR, chest, abdomen, pelvis CT, as we've discussed, and make the referral to the heart team for evaluation and management, for the TAVR, whatever. Each patient, because of their age, they will also have a left heart catheter. So then the whole process gets started. Now, if we find something funky, then we change directions, obviously. The other, more and more, especially if this is like low gradient, low flow, this, that, and the other, I am also becoming very diligent about looking for amyloidosis because, and I think as part of our standard protocol, I'm not going to endorse that everybody should have a technecian pyrophosphate scan, but you always should give consideration for doing that when in doubt.
Awesome. And when do you use MRIs in this situation, and do you see any role for TE at all in these patients?
So look, when do I use MRI? So you have a person with bona fide anaphylactic reaction to contrast agent on CT, okay? I coded last time. Okay, so that's a person. There's a person with significantly reduced GFR, and we have protocols in place as to what we do. There's only so much hydration you can do in a person with class 4 heart failure. And look, if the person's in dialysis, God is great. You just dialyze them. But if they're not, and they really don't want to go onto dialysis, then, you have to make a judgment. In that situation, what we end up doing is a non-contrast chest, abdomen, pelvis CT. At least that gives us a sense of calcification in the peripheral vasculature. And we do a non-contrast whole heart navigator. I mean, there's a MRI sequence. It's a short MRI. We don't do the full-on unless we are suspecting amyloidosis, et cetera. Even then, we have other ways of doing it. But specifically, if I'm analyzing for TAVR, then we would do a whole heart navigator-gated non-contrast MRI and do the same annular measurements that we talked about. But that's generally. Now, where do I go for TEE? Nowadays, very rarely. Now, okay, you have an anaphylactic person or a person teetering on the edge of renal failure, and the person has a old non-conditional pacemaker CRT device, and so they cannot get into MRI, and I need to do a TEE, and I need to do a TAVR. That person, I would do a TEE.
Awesome. That's very helpful. Thank you very much. I'm going to just deviate a little bit because I know your expertise in hypertrophic cardiomyopathies and all those other things too. So when you do MRIs in hypertrophic cardiomyopathies, and let's say it's kind of early stage, you're not seeing the typical scar, but it's kind of suspicious, then how frequently do you usually repeat an MRI on these people?
3 to 5 years.
3 to 5 years. Okay. Thank you very much, Milind. Thank you for spending your Saturday morning with us. Appreciate, all the information you have given. Vikram, do you have anything else, or?
I don't have anything in the chat, but perhaps maybe a speculative question I can ask. I think there's data emerging in the TAVR world that we don't really need necessarily like complete revascularization before TAVR. Angiography traditionally versus CTA, do you see a role of CTA kind of to rule out proximal disease so that people can proceed with TAVR if they don't have kind of overt angina symptoms?
So here's my take on it. On a 4D CT that is done for TAVR purposes, we generally do get a look at the very proximal vasculature, number one. If you have severe aortic stenosis, I am going to be a bit hesitant blasting them with beta blockers and nitro, okay? So you have to be careful about that. And in the setting of this ischemia trial data, mid and distal CAD, it really doesn't matter. At least that's what, if you were to believe ischemia trial data. And the only thing action is in the proximal coronary vasculature. So I do think you already get that data. But remember, this is, these are much older patients. So a common finding is going to be heavy calcification in the coronary artery. So almost, I would say, rule rather than an exception, you're going to be finding all these people. If you have atherosclerotic process to a point to develop severe AS, you have atherosclerosis in your coronaries in all likelihood. So the issue would be, you may plan to look for coronary arteries, but a lot of times there'll be blooming artifacts, et cetera, where you cannot clear the patient, and then they will end up getting a left heart catheterization. At least in our organization, at least on June 4th, 2022, if you were to get a TAVR, you're going to get a left heart invasive coronary angiogram before we proceed. Now, down the road, who knows, maybe technology will evolve, but at least at this point of time, that is not standard of practice.
Great, thank you so much. And thank you for taking the time to go over the discussion and questions.
Well, Dr. Schoenhagen is here. I mean, he's read as many TAVR CTs as I have, maybe more, because he spends more time in radiology. So, Paul, do you have anything else to add?
In general to your talk, or about the last question?
Yeah. No, I mean, did I miss anything to fill in the blanks?
No, I think it was well covered.
Okay, perfect. All right, beautiful. So, thank you so much.
Thank you very much. Please say hello to Rajul for me, and enjoy the rest of the summer.
Thank you. Bye.
I will move on to introducing our next speaker, Dr. Schoenhagen. Dr. Schoenhagen is a physician in the Department of Diagnostic Radiology in the Robert and Suzanne Tomisch Department of Cardiovascular Medicine. His clinical interest is focused on cardiovascular imaging with CT and MRI. He is involved in work related to the prevention of cardiovascular disease. He has a special interest in imaging of coronary atherosclerosis and imaging of the aorta and the aortic root. A native of Koblenz, Germany, Dr. Schoenhagen graduated with a degree in mineralogy from the Ruhr-Universität Bochum, Germany. I hope I didn't mess up any words there. He received his medical degree from Karls-Universität and doctoral degree from the Philipps-Universität Marburg, also in Germany. He received his initial clinical training in internal medicine and radiology in Stuttgart, Germany, and followed by residency in internal medicine at Cleveland Clinic, and subsequent fellowships in cardiology and cardiovascular CT also at the Cleveland Clinic. He has been appointed as staff at the Cleveland Clinic since 2003. He has been honored for his clinical research, which was focused on the implications of plaque vulnerability, intravascular ultrasound research, and the application of CT and MRI for atherosclerosis research. He has published numerous original and review articles in leading peer-reviewed journals such as JAMA, Circulation, JACC, European Heart Journal, Journal of Heart and Lung Transplantation. Dr. Schoenhagen is first author of a textbook of coronary intravascular ultrasound imaging and a textbook of cardiovascular CT. He has contributed several chapters in other medical textbooks related to his specialty interests. He's been invited to present his clinical research and experience at medical symposia and conferences in Japan, Europe, and nationally. He's a fellow of the Council of Atherosclerosis, Thrombosis, and Vascular Biology of the AHA. He's a member of the American College of Physicians, the European Society of Cardiology, and the Radiology Society of North America. He's also an affiliate member of the ACC. And thank you very much, Dr. Schoenhagen, for taking time out of your busy schedule and talking to us about the CT imaging of the aorta and acute aortic syndromes.
Thank you. It's certainly my pleasure to present here today, and thank you for the invitation and the nice introduction. I will present about the acute aortic syndromes, and in particular focus on CT imaging. Briefly, and it will become clear why I'm mentioning that Cleveland Clinic has a large network internationally, with the clinic in Abu Dhabi open for a couple of years. The clinic in London opened recently, but the original campus is here in Cleveland, Ohio. As you can see in this picture, this is actually where both Dr. Desa and I have our offices. This is the main campus or downtown campus in Cleveland, but there are multiple affiliated or family health centers and associated hospitals in the Ohio area. And as I will describe later, they work as a combined system, and that will become important in the context of the acute aortic syndromes. Briefly, and that kind of demonstrates that I want to show you a brief case in the context of the acute aortic syndromes, that's a 65-year-old male who had pain while he was playing golf on the weekend, somewhere in the Cleveland area. He and his friends then called EMS. He was transported to one of the emergency rooms within the Cleveland Clinic Health System and started to complain, in addition to the chest pain, also about left arm weakness. And then in the regional emergency room about right eye vision loss. He then had the CT scan in the regional emergency room. And as you probably see, and as I will explain, he has a type A aortic dissection with the flap here in the ascending and descending aorta. But there is also a dissection flap extending into the arch branch vessels with occlusion of the right carotid artery. And that obviously explains both the chest pain and the vision loss and neurologic symptoms. He was then transferred to the downtown campus for definitive management by helicopter, and I will come back to that. But before I do go into the CT imaging of the acute aortic syndromes, I wanted to make a few comments about CT in general. First of all, my talk beyond this slide will focus on CT, but obviously imaging of the aorta can also be performed with other imaging modalities, echocardiography, TEE, and magnetic resonance imaging with extremely good results equivalent to CT. Like oftentimes when you see images about multimodality imaging, you get the impression that it is defined by imaging a single patient with multiple modalities, which that may, for example, be valuable in cancer imaging and in other applications as shown here. But I think a more general description of or definition of multimodality imaging would be that you are working within a group that has knowledge about multiple imaging modalities, or all imaging modalities, and then within the colleagues who are involved with the different imaging modalities, the patient is directed towards the imaging modality that is best suited to answer the question. And in that context, when you're looking at the acute aortic syndromes, CT has tremendous advantages because it is so fast. The CT scanners are available in almost all emergency rooms. So you can basically, at the first point of contact, do a highly diagnostic scan. And the scan itself, as you may know, takes just one breath hold. It takes much longer to get the patient on and off the table, but the scan itself is very fast. So if I present today mainly about CT, that does not mean that CT is the imaging modality of choice for all aorta imaging, but rather for imaging in the acute setting. Then I wanted to make a few comments about CT in itself. As you know, CT is acquired in the axial as a stack of axial slices, but these slices together define a three-dimensional volume. And you can then reconstruct to any plane you want on the workstation, on any modern workstation, to planes you know, for example, from echocardiography or other imaging modalities. And that's very important, a key thing to learn with CT, how to use one of these 3D workstations. And if you have any chance within your hospital to do that, I would certainly pursue that, because it is so important now, not only in imaging or radiology, but also in many specialties or subspecialties of cardiology. For example, this is a reconstruction towards a 2-chamber view, here 4-chamber view, and a short axis view, by just tilting the planes on the 3D workstation. And then this is a view of the aortic root. Again, you shift the center line into the structure you're interested in, and then you tilt the planes to obtain these cross-sectional images. And the measurements of the aortic root are shown here as well. So that's the 3D reconstruction, and I truly encourage you to find an opportunity to practice that. The other important aspect on the work on the reconstruction side is to know about CT image windowing. Basically, you have a limited number of grayscales available to reconstruct your image, and you have to pick the center and the distribution of the grayscales so you see what you want to see. For example, in this image, for all of these 4 images with different window settings, you cannot see the lung because we shifted towards soft tissue. So to see the lung, this is non-diagnostic. To see the lung, you have to change the window setting to a lung window. In the soft tissue setting, though, you can go up and down, and you see here's an image that shows an aortic dissection, and you see the contrast-enhanced true lumen and the thrombosed false lumen, or perhaps it is an intermolar hematoma, and also down here in the descending aorta. When you set the window wrong, for example here, if it's too bright, you will not be able to differentiate these 2 lumina. If you set it too dark, you will also not be able to differentiate it. So it's very also important to know how to set the window in CT and to practice that on a modern workstation. The other or third aspect I wanted to comment upon is what is typically called gating or EKG synchronization. When we acquire a CT scan, we have to time or synchronize the acquisition to the heartbeat or to the cardiac cycle in a gated scan. And this is an example. This is a patient who had consecutive scans without gating or without synchronization and with synchronization. And the image without synchronization shows you this motion artifact. You see it symmetrically on both sides of the aortic root. Typical picture of motion artifact at the root because of the moving or the motion of the heart. And then on the right side, the same image acquired with synchronization or gating, and you see this artifact has disappeared. Now, on modern scanners like this one, the artifact is typically relatively minimal, and experienced reader can identify this as motion artifact. And there are so many CTs done in emergency rooms that are not gated or not synchronized, and the reader will be very comfortable to say that this is motion artifact and there is no concern for dissection. And that is certainly the case on a modern scanner. However, what you cannot exclude is that you have a very subtle finding, like a very focal intimal tear, which is hiding behind the motion artifact. And that is why in certain situations, a gated scan is required for CT acquisition in the context of acute aortic syndromes. This is just a picture how the gating works, although I today do not want to go into details of it, but basically there are different modes of synchronization or gating, and what they make sure is that with each of the table positions or scanner rotations or tube rotations, the acquisition window falls in the same part of the cardiac cycle in the 3 to 5 cardiac cycles that are needed to acquire the entire chest. Without going into details, which I have here on this slide, but it's a little bit, would take too much time now to explain and would probably go beyond this talk. What I wanted to point out to you is you have to number one, differentiate between a gated and a non-gated scan. For example, a scan for PE, pulmonary embolism, is non-gated, while a scan for coronary arteries is gated for sure. Obviously, any scan that is done right at the heart, like a coronary scan or a scan for pulmonary veins, you would need for sure gating to reduce the motion artifact, while a scan for example, pulmonary embolism, the gating will not help you much. In particular, in the more distal parts of the pulmonary artery, you get better results with a non-gated scan. So for scans that are limited to the heart itself, in particular, for example, a coronary scan is always gated. However, when you come to scanning of the aorta, there are situations where you would want a gated scan and other situations where you will rather prefer a non-gated scan, and I'll come back to that in a second. Now, so that's gated versus non-gated, or synchronized versus non-synchronized. And the other part of that is that once you're looking at a gated scan, there are different ways to gate, or different modes to gate. One is the retrospectively gated, and the other one is the prospectively triggered scan. And I don't want to go into details. Those the modes are defined by the scanner you're using and the indication. In general, you have to keep in mind that we balance the amount of detail and the radiation exposure. And you can, as a rough rule, think about it, the more detail you want, the higher the radiation. And the retrospective scan has more information, but higher radiation exposure. Prospective scan has may limit the information, but has a lower radiation exposure. So you can imagine if you have a relatively healthy outpatient who comes for a coronary scan, probably on the younger side, you would want to go for a low dose scan. And for example, with a retrospectively gated scan. On the other hand, if you have a sick patient who comes in the context of an aortic dissection and you want to do a gated scan or a gated component of the scan, you would rather go to a retrospectively gated to get optimal information. Now, again, I'm not going into details. The best way to learn more about that would be to find a rotation within your imaging department where you could learn about CT and MRI, and in particular get familiar with modern workstations, and or of course do some reading. Obviously, that little conflict of interest, I could point you towards the book from our group, which will come out soon in the 3rd edition, which is very image-based and a little bit short on text. Or, for example, the book by Mark Dewey, which is a very comprehensive textbook, including technique and imaging findings. Now, going back to CT for the acute aortic symptoms and applying the gated and non-gated acquisition as we just discussed, this shows it here again, an EKG synchronized scan where you have minimal motion at the root versus a non-synchronized or non-gated scan where you may end up with more motion at the aortic root. Although, as I pointed out, on modern scanners, motion artifact, even in a non-gated scan, is oftentimes not a big problem for the diagnosis. When you now transfer that to how we acquire CT scans, I try to show that in this picture, you will find two acquisition modes. One is called a gated forecore abdominal aorta, and the other one we oftentimes call stent protocol, which is basically a non-gated scan. Now you have to keep in mind that when we do a gated forecore abdominal aorta, only the chest is gated, at least on most scanners. So the chest is gated, and then we overlap and do the abdomen non-gated. In part because the gating takes longer, and to get through the entire volume of the chest and abdomen, we have to take this approach to gate only the chest and not gate the abdomen, also to reduce radiation exposure. So you end up with a scan that has a minimal motion at the root, but the arterial enhancement in the abdomen may be somewhat limited, and the data set, although complete, is interrupted at the level where you have the visceral branch vessels coming off. And that can be a problem if you're looking in particular at the process that includes the forecore abdominal aorta, because there you would want to have a continuous acquisition at the visceral branch vessels and also optimal enhancement of the entire aorta, including the branch vessels. The other protocol, the non-gated protocol, is basically a quick spiral scan through the entire chest, abdomen, and pelvis. There you have uniform or almost uniform enhancement of the entire aorta and the visceral branch vessels, and you have a continuous data set, including continuity at the level where the visceral branch vessels come out. So you see that depending on the question, you may choose either a non-gated or gated protocol. For example, if you're thinking about the type A dissection and you want to define the ascending aorta, you would rather want to have a gated component or a gated scan. On the other hand, if you have a type B dissection, where you want to define both the descending thoracic and abdominal aorta, including visceral branch vessels, the non-gated option would be much better. And that's how we decide clinically which protocol to choose. Now, in the acute setting, optimally, you would want to combine both. And that's what we did with a protocol we call ICU dissection protocol. And basically what we do is we acquire a non-gated scan of the chest, abdomen, and pelvis as a continuous acquisition first. That provides us the entire aorta, branch vessels with very high quality. It may be a little bit limited by motion at the root in some cases. And for that reason, we immediately follow with a gated acquisition of the chest. That allows us now, the two combined, to answer any question we want, both for the descending thoracic and abdominal and the ascending aorta. And that's why we changed to this protocol, which we call ICU dissection protocol. Occasionally, we do a non-contrast acquisition first, and I show you why. That's to define, or to better define, the intermole hematoma in particular for a reader who has not that much experience. Briefly, there are several classifications of the acute dissections. Some are more imaging classifications, others are more surgical classifications or management classifications. Probably an easy way to define dissection would be to define a dissection that begins beyond the left subclavian artery as a type B dissection. It's easy to define a dissection that involves the ascending aorta as a type A dissection. It gets a little bit more tricky if the dissection starts somewhere in the arch or has involvement of the arch but not the ascending aorta. I think from a clinical point of view, initial management and acuity of surgical consultation or management to call everything proximal, that has involvement proximal to the left subclavian type A, at least for initial management, is probably clinically reasonable. There are these newer surgical classifications try to define by the location of the intimal tear. And then you find scenarios where the tear is in the proximal descending aorta, but there is suspected retrograde extension into the arch and ascending aorta. And these cases may be managed like a type B, but it gets a little bit tricky and a little bit complex. So I think a classification clinically into type A, type B, relative to the origin of the left subclavian artery is clinically more feasible or reasonable. Then there are also different types or classes of dissection. The one which is called class 1 is the dissection where you see the dissection flap, which is probably the easiest to identify and is almost never missed. Class 2 is the intermole hematoma, where you do not see, like shown here, you do not see contrast flow in the false lumen. And that may be either because there is no communication between the true and the false lumen and just bleeding into the wall, or because the false lumen is thrombosed. And these, as I told you, if the image window is not set correctly, they are occasionally missed by inexperienced readers. And that is also the reason why inexperienced readers prefer to have a non-contrast scan, because if you now, so on a contrast scan, the contrast enhanced lumen has a Hounsfield unit or density of about 350 or higher. And the acute blood products in the wall have a Hounsfield unit of 60 or 70. Experienced reader can easily identify that and can put a region of interest here to measure the Hounsfield unit. On the other hand, if you do a non-contrast scan, the true lumen without contrast has a Hounsfield unit of about 30. On the other hand, the false lumen with the blood products has a Hounsfield unit of 60 or 70. So it almost lights up and is easy to see or not easy to miss. And that's why this is traditionally preferred as part of the dissection process, particularly if you're dealing with an inexperienced reader. And then there are other classes, like, for example, this limited intimal tear and little outpouching. So you see here in the ascending aorta a small tear and small outpouching, oftentimes surrounded by intermole hematoma. This is also a type A dissection process, and this patient would also, let's say he comes in the middle of the night with symptoms of chest pain, this patient would go to the operating room during the night. So sometimes people say it's only a intermole hematoma or it's only an intimal tear, or they think they are different entities, but they are not. They are all dissection process. They all may immediately go to the operating room. So they are just different classes of, or on a spectrum of disease process. Now, I want to show you a few examples. This one, type A dissection, almost nobody would miss that. You see the dissection flap here in the ascending aorta. Much more subtle on this side, dilated ascending aorta with this focal outpouching. And I don't know if it is seen on this slide, but you would see it on a good workstation. There is a small intermole hematoma surrounding it. Again, both patients should be immediately admitted to an intensive care unit, should be immediately seen by a surgical team. And unless there are reasons not to take them to the operating room, both of these patients would immediately go for ascending aortic repair. This again is the intermole hematoma picture I showed you already. Again, on the contrast enhanced scan, an experienced reader will identify the wall thickening, will measure the Hounsfield unit and identify that as an intermole hematoma. Again, the intermole hematoma is a dissection process. So you're looking here at a type A aortic dissection, immediately surgical consult and operation unless there are contraindications. And this is the non-contrast scan. As I showed you, the wall, the blood in the wall is well defined or easy to see in the non-contrast scan. You also have to differentiate between uncomplicated and complicated dissections. Here you see a process which maybe has the shape here of a penetrating ulceration, type B dissection, but you see there are all these blood products, both probably in the wall of the aorta, but also the stranding and the blood products in the mediastinum. So you have evidence of rupture here, a ruptured dissection process, and you also have evidence of hemorrhagic pericardial effusion. So a complicated dissection process, which probably you would also be looking at one form or another of an immediate surgical repair, either surgically or endovascular, if the area can be covered by an endovascular stent graft. Then, either in a traumatic but also in non-traumatic settings, there are more subtle findings with these focal intimal tears. It's not a good image. Maybe the patient was so sick that it didn't image well, but there is again this focal outpouching, focal intimal tear, perhaps seen here and here. It seems like in this setting, in this case, in a traumatic setting, motor vehicle accident and so on. And then just to point out to you, there are also not only subtle findings, but also situations where you can be misled. For example, in this patient, you're looking at just a little bit fluid in the pericardial fold that drains up along the ascending aorta, and that sometimes this fluid in the fold along the ascending aorta can sometimes almost look like an intermole hematoma and may require a lot of experience to differentiate. Again, I cannot cover everything in the limited time. And we do have, from our group and obviously many others, summaries of the acute aortic symptoms in ours. You have these cases described on a clinical basis, and then the images are shown with interpretation and subsequent management. Obviously, imaging of the aorta is not easy and takes a lot of experience. And again, if you have a chance within your system to do a rotation in imaging, that would certainly be extremely helpful to get a deeper understanding. And now, in the rest of the talk, I want to come back to how imaging in nowadays, in the context of the acute aortic syndrome, is integrated into an overall approach within larger healthcare systems or larger networks to deal with these patients. There are several large referral centers, which are oftentimes more regional centers, to deal with these acute aortic syndromes, similar like a situation for stroke or for acute myocardial infarction, where the initial point of contact may not be the center where the subsequent treatment is performed. Treatment, obviously, in the context of acute aortic syndromes can be a surgical repair, an endovascular stent repair, or initial management in the intensive care unit and conservative management in the setting of type B dissection. Now, these networks nowadays are very complex, and I will show you that. But I wanted to go back with one slide or two, how this has evolved over the last few decades. You may know that CT, the first CT scanner, clinical CT scanner was kind of developed in the 1970s. This shows one of these earlier scanners. This one was only for brain imaging, so a small opening here where only the brain would fit in. And you see back then the images were printed on Polaroid. This is Gottfried Hounsfield, and that's where the name Hounsfield unit comes from, obviously. And he got the Nobel Prize for that development. This shows the first scanner that the Cleveland Clinic bought in the 1970s, coming here into the building. And by the way, the company EMI that developed these first scanners also had the contracts with the Beatles. That's where the name comes from. Now, back then, also sharing of the results of the images was a little bit cumbersome. You know that back then, many of you may have still seen that films were printed on these film sheets. They were housed in these huge archives, in these paper containers, and they were not easy to share between hospitals or even between hospital locations within the single hospital system. Later, then technology switched to CDs, which are still used today to exchange data. So we occasionally still have patients where we cannot get the images electronically, and the patient would arrive with CD, and we then have to load the CD in our servers, and that's obviously an unnecessary time delay. There was also a time when we still communicated with pager rather than cell phones, or with landline phones when we were on call, and somebody would not be at the hospital, would have to call back using a landline. All that has changed in a modern network like exists now all over at least the United States. This is an example of our emergency care network, which covers multiple cardiovascular conditions like acute MI, stroke, other neurologic emergencies, but also the acute aortic syndromes. At Cleveland Clinic, the definitive treatment in many cases would be at the downtown campus here in downtown Cleveland. But the initial point of contact may be in one of the many emergency rooms or associated hospitals in the entire region. And the transport in many cases is organized by our critical care team, and both with rotor wing and ambulances, including so that then the initial point of contact is somewhere not necessarily downtown Cleveland location, and the patient is then, if necessary, brought to our downtown location for definitive management. Admission, by the way, in this context of the acute aortic syndrome, the initial admission is directly to the cardiac intensive care unit, bypassing the emergency room, where the patient is then immediately seen by the intensive care team and vascular and cardiovascular surgery. And this just shows that this network and this approach in a regional network goes beyond the Cleveland itself and actually beyond Ohio. Lots of patients who would be transferred from hospitals from Pennsylvania, Indiana, in particular with the short transport time when you're flying with helicopter. Now, on the imaging side, this network is mirrored by a modern, what is called private medical cloud. And basically what that describes is the following. All the scanners in our system, which are more than 60 CT scanners, send immediately, once the examination is done, send the data to our central data archive, or then data center, which is fairly large. And that includes data that comes from our mobile stroke unit. So all these scans sent to the central data center. And regardless if you're sitting in the reading room just next to the CT scanner, or if you're sitting miles away in a different hospital, you access, when you open the workstation and when you look at the images on the workstation, you access the images from the central data server. And as shown here, you can obviously also access these data on a mobile device. We can look at the images on our company cell phones, at least for initial screening. This is shown here. So the images come from the data center to the workstation, and that could be a dedicated workstation in one of the reading rooms. It could be electronic health record. We have the images integrated into the electronic health record. So everybody, this is the workstation in the intensive care unit. Immediately you can look at the images there, or we can look at the images on mobile devices, including the cell phone. Now, there is a third component, and that is a cloud system that allows image transfer between hospitals. Our cloud system is connected to more than 300 hospitals. And with that cloud system, we can exchange images, send or receive images from these hospitals within minutes. Just need to call them, or they need to call us. And we can send the images back and forth. In the acute setting, hospital transfer, that is covered by HIPAA rules, continuation of care. So it does, in the acute setting, not need additional permission from the patient once, obviously, the permission is given to transfer the patient. So basically what we can do is we can simultaneously transfer the images and the patient in these acute cases through these cloud systems. And what that means is, if you think about a patient at a hospital outside our healthcare system, where we don't have the images right on our server, central server anyway, we would ask the hospital, the referring hospital, to send us the images. If everything goes well, that takes a few minutes. So before the patient even arrives at our hospital, we have the images, we share them between the intensive care team, imaging team, the surgical team, and a decision about need for management. Is it just management in the intensive care unit? Is it surgical management, type of surgical management, can be made before the patient even arrives, and preparations can be done to be ready to provide necessary care in a very timely manner. Let me go back now to that case I told you about already, the 65-year-old patient with the pain on the golf course. Again, initial contact, EMS system brought him to one of the emergency rooms within the healthcare system. There, the initial imaging was performed, and as I showed you, was a type A dissection with occlusion of the carotid artery. Based on this diagnosis, he was then immediately transferred by helicopter. That probably was a 10-minute ride at the most, to the downtown campus into the intensive care unit. The team, ICU team, surgical team, imaging team was aware and had discussed the imaging findings prior to arrival of the patient. So the management strategy was already decided upon, and this patient underwent what is called a frozen elephant trunk repair. So basically the root was left in place. There is a surgical graft of the ascending aorta, which then overlaps or is actually connected to a stent graft in the hanging or extending into the descending aorta with a side stent in the left subclavian artery, and the innominate and carotid artery was repaired. This shows the carotid artery, which is now open after the surgery, and the patient had good recovery. So the imaging in an acute network obviously has a couple of goals there. One would be to, within the hospital system, in multiple locations, acquire images with standardized protocols, and then make the images available throughout the healthcare system, as I showed, to be able to share them both on workstations and mobile devices. And that is possible through central cloud servers or a central data center, as I think now is more or less standard. Imaging diagnosis is obviously performed by a human reader, and that, in my opinion, will not change for the foreseeable future. Modern workstation, though, allow automated steps and support the human reader with automatic analysis. That can be measurements, that can be perhaps even suggesting diagnosis or finding or identifying findings, like, for example, all workstations, modern workstations, have a system that allows to identify small lung nodules. And for example, I run my studies through these lung nodule finder routinely. And these programs, I mean, once they're implemented on the workstation, they're basically automated computer algorithms that support diagnosis. They're oftentimes described as artificial intelligence, which to some extent is true. The true artificial intelligence goes into development of the algorithm. Their true artificial intelligence or machine learning approaches are used once the algorithm is implemented on a clinical workstation. That the better description would be an automatic detection. So if I summarize what I wanted to tell you beyond just the image appearance of acute aortic symptoms, then it would be here that the approach to acute aortic symptoms in modern healthcare systems could be described as an online network of disease experts, where we are able to remotely review and triage images by a group of subspecialists. It allows us to early notify the clinical teams involved in decision-making and management. We can discuss findings and plan ahead before, in many cases, the patient has arrived to the tertiary care center. And we hope and we believe that this improves care of these patients in a larger and modern healthcare network. Thank you very much.
Thank you so much, Dr. Schoenhagen, for that excellent talk. and in particularly sharing some of the kind of recent advances in how images are shared. Particularly, I think this is really changed the way people are able to access information in the acute setting. And truly, in the current era, you can get an opinion pretty instantly from an imaging expert remotely to be able to make clinical decisions. So that was definitely very interesting to hear about. So I'm going to have a quick look and see if we have any questions in the chat. So there aren't. So, just a question I have is, for, let's say somebody presenting in the acute setting in the emergency department who is being suspected to have an acute aortic dissection, what is the typical protocol that you would recommend that they should undergo? And are there any, nuances to that?
Yeah, I mean, what you see is a variety of problems protocols used depending on the expertise and probably history of a particular hospital or emergency room. There is a lot of studies that are initial studies that would be non-gated, basically a contrast enhanced scan of the chest and abdomen. There are these protocols that are then other hospitals or emergency rooms do a gated chest and a non-gated abdomen. And as I told you, we have changed to this combined protocol that does continuous acquisition chest, abdomen, pelvis, and a gated scan. I think for the majority of acute aortic syndromes or dissections, either scan is good enough. And you can diagnose a type A, type B dissection on either scan. A non-gated scan occasionally will limit you because of the motion artifact, but on modern scanners, that's really only occasionally. So I think if I had the choice, I would do the protocol we are using, which has the non-gated chest, abdomen, pelvis, and gated chest. But I think if a modern scanner, which I would define 64 slice or above, more recent generation, I think whatever scan is done more likely allows the initial diagnosis. And the number of scans where we now need to repeat a scan, let's say we get an initial non-gated scan from an emergency room within or without our system, is very small. And it occasionally happens that the motion artifact is so significant or the clinical scenario is so complex that we need to repeat a scan, but is nowadays relatively small number. It used to be a much bigger problem, but not anymore.
Great, thank you for that.
Thank you very much, Paul. That was very informative, very comprehensive. That was a great talk. I just had a question about, the contrast shortage, which is being experienced by multiple centers. I don't know if you're experiencing that at the clinic, but do you have any suggestions about alternative? I see some centers leaning towards MRAs and stuff, and we just wanted to know what your thoughts are about all those.
Yeah, I mean, obviously for elective studies, and we are affected by that as well. And you would first of all think, can the scan be delayed, which obviously for many elective studies would be an option, but not in the acute setting. You would then ask, can the scan be done without contrast? Again, for many imaging of the aorta, you could do a non-contrast scan if you're just looking at size. But in the acute setting, obviously, where you need to define dissection, that's not an option. And then you could wonder, are there alternative imaging modalities? Could you do a TEE? Could you do an MRI scan? Which is obviously the MRI for dissection is as diagnostic as the CT. The only problem is that in the acute setting, if the patient is really sick and coming with a concern for an acute dissection, you probably would be reluctant to take the patient into the MRI scanner and do a 10-15 minute examination where the monitoring of the patient is limited. So in the acute setting, I think you would rather want to save the limited amount of contrast you have for the studies where you absolutely need the contrast enhanced scan. So you would prioritize acute or CT imaging for acute aortic symptoms. You would prioritize your contrast volume for these patients, and then think about the alternative modalities or alternative approaches in more elective patients.
Awesome, thank you. And there's also been some conversation about CTPE. I mean, are you doing MRAs at all for those patients, or what are your thoughts on that?
Sorry, I don't quite.
For instead of CTPE, for like PE rule outs, there are some centers who are trying to go towards doing pulmonary vein angiograms, magnetic MRAs kind of a thing. Is your center doing anything like that, or?
Yeah, and now I have to tell you that I'm not reading CHEST or PE, but there is the discussion across all our imaging sections where the contrast can be saved, and that is discussed, and I think is implemented to some extent, that either nuclear or is done for patients for PE. Yeah.
Awesome.
But the details I don't know.
Right. Thank you.
I have a question here posted for you, Dr. Schoenhagen. Cardiac gated CT pulmonary angiogram can help with assessment for coronaries as well. Do you think, especially when patients present in the ED, any issues with cardiac gating for those studies? So,
yeah, I give you a two-part answer. One would be technically is feasible. So there are scan protocols that are gated with contrast that are combining an assessment of the aorta, the pulmonary arteries, and the coronary arteries. We are not using it, and I'm happy about that. And for the following reason, I don't believe that when a patient presents to the emergency room, you're thinking at the same time about dissection, acute MI, and PE, because the clinical presentation in the initial assessment with, for example, electrocardiogram, troponin, or D-dimer is very different, and the timing. So I think these protocols are geared towards a faultless imaging approach rather than a clinical assessment. And in my opinion, I believe that imaging should take a secondary role after history and physical examination and the clinical thought process, rather than just a wide imaging approach for everything. I believe that both for CT in the setting of this triple rule out, which I don't believe in. I also, you oftentimes hear the term one-stop shopping, that you would do, for example, an MRI scan where you assess everything at the same time. I think whenever you do take this approach, first of all, I think it's clinically faultless. And second of all, I think that you water down the components. So any scan, particularly any CT scan, is best when you focus it on a clinical question. Then you get optimal results. You can do everything, but then you will get poor results or less optimal results for everything. So short answer, technically possible. I would not recommend it.
I agree. I think clinical evaluation is the key with a focus scan. I have another question here. Are there any situations currently that TEE may be preferable over CT for acute aortic syndromes?
Yeah, I think if you had a patient who is so sick that you are reluctant to take him to the CT scanner, and you would rather, together with the surgeons or without, think about an assessment. So we have sometimes done that when there was uncertainty from the initial scan, the patient would already be on its way to the operating room or perhaps already induced. And then the TE would be used to confirm or not confirm the diagnosis. I think there the TE is extremely valuable in situations like that, because you can do it bedside in the intensive care unit, or and there is always a risk taking these sick patients to the CT scanner. We probably all have seen patients who went to the CT scanner and then decompensated or coded in the CT scanner, which is obviously something very unpleasant. So I think yes, and again, both TE and obviously also MRI, the diagnostic accuracy of these is equivalent to CT. Is only, like with anything else, a matter of in what scenario to choose one test or the other. But the diagnostic value is the same for these, or very comparable for these modalities.
Thank you so much. One scenario I can think of is, somebody who has a history of severe allergy to iodinated contrast. Maybe an alternative modality may be suitable, because kind of even with the emergent desensitization protocol, you still have a little bit of a delay.
Yeah, that's certainly true. You could think about, TE would be a very good option, and I completely agree with you there too.
Thank you, sir. Dr. Ashwath, back over to you if you have any additional questions.
No, I would just want to thank Dr. Schoenhagen for spending his Saturday morning with us. We understand his busy schedule, and that was a great comprehensive lecture. We'll have recordings up on the website within the week sometime. So thank you again, Paul, very much.
Thank you very much.
I will move on to introducing our next speaker, Dr. Georgios Christodoulidis. Dr. Christodoulidis is a clinical assistant professor in internal medicine, cardiology, and also radiology at the University of Iowa. He did his education in med school at the University of Patras, from Patras in Greece. He did internal medicine residency in Winthrop University at New York. Did a research year at Icahn School of Medicine in Mount Sinai, New York, followed by cardiology fellowship at Robert Packer Hospital in Guthrie Clinic, Pennsylvania, and a fellowship in advanced cardiac imaging at Mount Sinai St. Luke's in New York. He has been on the staff at University of Iowa for quite some time, where he's been actively involved in teaching the fellows multimodality imaging, including cardiac CT. He has published extensively in this area. He has lectured multiple times for us at the Iowa chapter of the ACC, and we truly appreciate his participation and his expertise. So over to Dr. Christodoulidis. We cannot hear you, Georgios.
Good morning, everyone.
Yes.
Can you hear me now?
Yes, I can hear you now.
All right. Sorry, I don't have a video in my office, unfortunately, so I will have to do it without my video here. Hopefully, that should not be a problem. You should be able to be seeing my screen, though, right?
Yes, we can see the screen.
Okay. All right. So, as Mahi, thank you for the introduction. I'm Georgios. I'm one of the cardiology staff here at the university, and I will be speaking today about the cardiac CT basics: when, why, and how. we're actually planning to do this lecture a little bit earlier, but due to some scheduling conflict, we push it out a little bit, but you know, still be a very relevant lecture for everyone that is interested in CT and everyone that is actually planning to take the boards. Extremely important things for the boards also. All right, so I'll move along. First, we're going to start with the when. And when is essentially what is the appropriate use of cardiac CT. And whenever we are speaking about appropriate use of cardiac CT, obviously it comes to mind the 2010 appropriate use criteria, kind of old, but still very relevant. And also an additional paper that came a little bit more recently last year from 2021, which is essentially an expert consensus document about the use of coronary CT angiography. All right. And, you know, obviously this could be a very long lecture, but I'm going to try to summarize it, you know, in a brief, like 5-6 slides, because you have a lot to discuss about the how to perform a cardiac CT. So starting with the coronary CT for native vessels, you can actually do this study in, it's probably one of the most common use actually, in patients with or without coronary artery disease who presents with stable chest pain or any angular equivalent, and they have low intermediate pretest possibility. All right. So remember these things: stable chest pain, low intermediate pretest probability. And how do you determine the low intermediate pretest probability? You guys all know about, you know, the definition of chest pain, and then you use your classically you use the Diamond Forrester model, right? Now, I will note though, and that's important, I will explain you why, that if your patient is able to exercise and has interpretable EKG, the AUC give it a 7, which is essentially still appropriate, but it doesn't give it a solid 8 or 9 that is giving to the case of the patient with a stable chest pain that has an uninterpretable EKG or unable to exercise. And the reason that I'm bringing up this up, again, it's you can use it in either two of the cases, but some insurance companies may give you a problem if the EKG and the patient is able to exercise, and they're going to tell you that patient needs to do an exercise stresses first and then decide whether you need to do the cardiac CT. All right. Now, moving along, an excellent use of the cardiac CT is in patients that you already did a functional test and for whatever reason is inconclusive. And then instead of going ahead and doing a coronary angiography to decide what is the answer, you can easily do a coronary CT and take the answer from there anyway with a non-invasive way. Now, moving along. So the first two indications were in stable patients. Now we're going to the acute chest pain. In the, what do you call in the ED settings? I'm sure that you guys were aware about, like, it's almost now 7-8 years ago, there were multiple studies that came out about the use of cardiac CT in the emergency department, and which essentially shows that this is a feasible thing to do and can actually have very good outcomes, better results with utilization, fastest time to get the patient out of the ED. The expense out of it was basically that you have more downstream cardiac catheterizations due to the increased sensitivity of the cardiac CT, which of course came with the expense of a little bit of decreased specificity. The end result is that this is a very acceptable option to do. Again, you have to select your patients. It should be a low intermediate probability patient. It should have a normal EKG and biomarkers, right? You don't want to be doing someone that comes in chest pain and ST depressions. You're not going to be doing a CT. And also generally a TIMI score of less than 4 in these cases, right? And then finally, something to remember that CT is rarely appropriate in a very low risk symptomatic patient, right? You know, we here at the university, we get a lot of young students that they come, you know, 25-year-old that they come with chest pain. That's not the patient that you're going to be doing a coronary CT. That's probably, if it's a non-cardiac pain, maybe you don't need to do anything. And if you're going to do anything, you're probably going to do an exercise EKG. Having said that, you know, sometimes you end up doing, if a patient, you do an exercise EKG and it's negative, and then the patient is coming again and again. At some point, you may end up doing it. I'm not saying that it's, you know, impossible to do it, but I'm just saying that it's rarely appropriate. Moving along. What about the use of coronary CT post-revascularization? So this is a subject of quite a bit of discussion in the literature. And, for anyone that is going to be taking the boards, especially the general cardiology boards, generally we avoid doing a coronary CT in patients with stents, right? Prior stent vascularization. The exception would be if you have a pretty wide stent, like more than 3 millimeters, then that would be an option. And you notice here that I say may be appropriate. So, the terminology is important here. There is the option that you say appropriate, may be appropriate, or rarely appropriate. And if you wanted to put it in the numbers of the AUC criteria, I'm sure that you guys are aware of the AUC criteria. It's essentially anything 7 to 9 would be the appropriate, and then 4 to 6 would be the may be appropriate, and then less than 4 would be the rarely appropriate, basically. So stents greater than 3 then would be the may be appropriate. Generally, I would stay away of doing the cardiac CT in patients with small stents. The problem with that is you end up having blooming artifact from the stent struts. You also have beam hardening artifacts, which really look like an ISR on the imaging or the cardiac CT, and that's why we tend to avoid it. And we probably go more towards a functional test like a nuclear or a stress echo. Now, what about the use of cardiac CT in bypass surgeries, right? So this is a little bit tricky. You have to answer the question to yourself first, what are you looking for? If you are looking for graft patency, then the cardiac CT is an excellent test because, the grafts are pretty big. They're generally they are not moving that much, right? So you actually have excellent visualization of the grafts, right? So if you're interested, you're like few months after a cabbage surgery. I actually had a case last week that I did that. They were interested in lima patency, and you are specifically looking for that. You do your cardiac CT and you give an excellent answer to that, right? However, if you are interested in generally, is there ischemia in this patient with chest pain that has prior cabbage, then it gets a little bit tricky because you're going to have an excellent answer for the grafts, but you're not going to have a very good answer for the native arteries, because the patients with prior cabbage, usually their natives are like heavily calcified, they have a lot of disease, and you're generally going to end up giving them some answers that, they're going to be a little bit equivocal, because, as you know, when you have heavily calcified vessels, you tend to have that blooming artifact that tends to overcall disease, basically. So the long story short is that if you're looking for the grafts, you do your cardiac CT. If you're looking for overall ischemia, probably doing a nuclear or a stress echo is probably a better option. And then finally, a very good use of the cardiac CT is actually in a patient that already had a history of cabbage and you're thinking of a redo surgery. That's actually a very appropriate test to do to visualize the structure, see what is the grafts in terms of where you're going to be your redo sternotomy, if there is any risk of perforating the prior grafts or anything like that. And that's kind of comes mainly from the surgeons. There is some surgeons in our institution that they would always ask for a cardiac CT before their redo surgeries. Some others not that much, and they end up doing like a regular chest CT. Now, should you be doing an FFR CT or a CT perfusion with your CTAs? Well, the answer is yes, it might be appropriate in specific situations, though, that you end up having intermediate stenosis on CTA. And, the classic intermediate situation is a 50 to 70 stenosis, but you can actually broaden it up a little bit, and you can actually do it more or like 40 to 80% stenosis, because, we're not that accurate to say that it's 50 and it's not 40. So generally, anywhere between the range, if you have disease in the 40 to 80% stenosis, it's very reasonable to perform an FFR CT or a CT myocardial perfusion. And by doing that, what you end up doing, you increase your specificity, right? And therefore, you are increasing your positive predictive value and your overall diagnostic accuracy. So I think this line here is very, very useful for you in the thermal purposes. They may ask you, you have this situation, you end up doing your CT perfusion, what are you improving? And you're improving your specificity and your positive predictive value, right? And finally, you should know that the FFRCT and the stress CT perfusion are generally comparable in their diagnosis utilities, so therefore you can use either of the two. Now, you can actually use the coronary CT for conditions other than chest pain, right? So one of them is, and we have done it quite a bit here, if you are having a non-coronary cardiac surgery, right? So what would that be? Let's say you have a patient with endocarditis, for example, right? And you are planning to do your surgery for the endocarditis, and you're wondering, does this patient needs any coronary bypass at the same time? And which patient you will, you know, in the old days, you will be doing coronary angiograms in all these patients. Nowadays, if the patient is low to intermediate risk, then you go ahead and do a cardiac CT and you save yourself for the invasive test, especially, you know, and sometimes you have the interventionalists that are worried about doing a coronary angiogram in a patient that has aortic endocarditis, and they are, you know, they're afraid when they're going to go in, they may cause dislodging of that, you know, big chunk of endocarditis that is on the coronary cusp or anything like that. Now, keep in mind that you shouldn't be doing the cardiac CT in someone that you wouldn't be doing a coronary, an actual angiogram anyway, right? If you have a young patient, 25-year-old, that you wouldn't be doing a coronary angiogram, you're not going to be doing a non-coronary cardiac CT either, right? So classic indications would be, you know, a 40-year-old male or a 45-year-old male, not much of cardiac history that comes with that, you know, for whatever reason, non-coronary cardiac surgery. Now, another important thing is this one here. Should you be doing a cardiac CT for pre-op evaluation? And, you know, if I wanted to give you one answer here, it would be probably no, right? Now, the answer is probably a little bit more uncertain. Why? Because, you know, there is some situations that, you know, for whatever reason, the functional test is contraindicated, or you did it and it's a little bit equivocal, and then maybe you should consider it. But generally, if you have a question on the test, or even in your general practice, if you want to do, if for whatever reason you decided to do, you need a further cardiac evaluation for pre-op testing of non-cardiac surgery, cardiac CTs should generally not be your first thing that comes into your mind. All right. Another excellent use of the CT would be in if you have newly diagnosed heart failure. It's an excellent test to look at the coronaries. It has very high sensitivity, so it's going to give you a very good answer whether the coronaries is the cause of the newly diagnosed heart failure. Again, you are going to be using that in the low intermediate risk patients. You're not going to do a coronary CT that comes with new heart failure in a 60-year-old diabetic, right? Once you have a high pretest probability, you probably go directly to the coronary angiogram. And then finally, if for whatever reason you are suspecting coronary anomalies, then cardiac CT is by far the test of choice. It gets an AUC of 9. It's essentially the best test that you can probably do for coronary anomaly evaluation. Moving along, there's quite a bit of non-coronary use of the cardiac CT though, that they keep coming and they keep adding to our list of things that we can do. Classic one would be a patient that you want to rule out the LA thrombus, let's say prior to cardioversion. We all know that T is the first test that comes in mind, but you know, if for whatever reason there is some risk that, you know, or some concerns, then cardiac CT is an excellent test to do. There is a ton of studies that have shown that has excellent sensitivity for excluding cardiac thrombus. If you decide to do that, I think extremely important thing to do is that you have to remember that you need to do delayed images. Why is that? Because a lot of times you see underfilling of the appendage there, but it's only because of slow flow. And then subsequently you are 1 milli delays, and then you have nice filling, and then you just call that underfilling that you initially saw is not a clot, it's actually just slow flow, and you can go ahead and do your cardioversion. It's very, very common scenario, and if you don't do your delays, you're going to be calling way too many clots without good reason. Now, other option is it's actually a pretty decent test for evaluating cardiac structure and function, but it should not be your first test though. So you are going to be using that in that regard if your echo is, you know, for whatever reason, a bad quality, and then generally MRI is the next thing that comes to your mind. But if for whatever reason you cannot do an MRI, let's say you have a pacemaker that is not MRI compatible, then you go ahead and give your cardiac CT. You can get a pretty accurate assessment of the LV function, and you can get a very accurate assessment of the size of the LV or the RV also. Now, Moving along in the prosthetic valves. So this is actually pretty interesting, and I have to be honest with you, this can be actually lectured just by itself, right? But I'm going to try to summarize it in 2 lines here. So if you are having a prosthetic valve, let's say it has worsening gradients by echocardiography, cardiac CT should come to your mind, right? Now, the first, of course, TE is coming to your mind also, right? And the question is what you should be doing between the two. So let's start with mechanical valves. If you have a mechanical valve, right, with worsening gradients, and you are wondering what to do, the next question that you should have to your mind, where is the position of the mechanical valve? If it's in the mitral position, then generally both of the tests are pretty good. People tend to do the T first as an option, and T, obviously I do a lot of T's myself also, and generally the mitral valve is very well evaluated, and you get your answers just by doing your T. And then if you have other questions, you can still do your cardiac CT. On the other hand, if it's actually in the aortic position, then it gets more tricky. Based on the guidelines, you can do both of the tests. I will tell you my personal opinion. Again, I do both of the tests. I like both of the tests, and I do find that on the in the aortic position, mechanical aortic valve, generally the T is not a good test. Why is that the case? Well, because you get all those shadowing from the mechanical prosthesis, and it's extremely tough. It's a hassle. You spend an hour doing the T, and then you still don't have the answer. Whereas with the cardiac CT, I think you have perfect, very good visualization. There is papers out in the literature that they tell you the opening and closing angles for each specific prosthesis. You can actually see if there is any evidence of thrombus or Panus. So generally, I tend to prefer the cardiac CT or mechanical valves in the aortic position. Going on the prosthetic valves, the bioprosthesis, again, you can do either of the two. Again, the boards tend to prefer starting with a TE, but I have done a number of cases that you have done on prosthetic valves, and it can actually, it's a very good test. You can see leaflet motion, you can see leaflet thickening, and it can give you quite a bit of, and also you can also, by evaluating the Hansfield unit, you can decide whether, it's more of a Panus that is there or more of a thrombus you can actually see there. So, it can give you a good idea of what is happening and, possibly an idea of how you should treat the patient. Another very useful information, another very useful test that you can be doing is if you have a patient with that you already diagnosed the endocarditis, and so you already did your T basically, and you use that in a prosthetic valve to see if there is, to get an idea prior to surgery what you are going into. So it's going to give you an excellent information about whether there is abscess, whether there is like pseudoaneurysms, fistulas that you may have missed with the T, especially if there is a lot of artifacts there on the T, especially in the mechanical prosthesis. So in general, it's a very good test that you can do in addition generally to T in this case. Moving along, you can use it for cardiac masses and pericardium, although as you know, generally MRI is preferred, but if MRI for whatever reason is not an option, then the cardiac CT is a pretty good test also. And then last but not least, in structural heart disease, this is extremely important. You guys already have the lecture on that. So pre-TAVR, pre-TMVR, pre-ablation, and more recently are doing for pre-Watchman also. Extremely important. Nowadays you cannot even imagine doing a TAVR without doing a cardiac CT before. And I would say in our institution is probably, this last indication here is probably like half of the CTs that we do overall, basically. Moving along, let's go to the how are you going to be doing a cardiac CT now, right? And so what should you be doing for performing it? Now, the first thing that you should be doing is the assessment of the patient, even before you order the cardiac CT. And this is something that everyone should know, any cardiologist should know, even if they are not interested in cardiac CT. So extremely important is to know your contraindications, right? And we're going to review one by one on the next slide. Subsequently, we generally tend to say that the patient should be NPO for a couple of hours. That's kind of a remnant of the old iodine contrast that they would cause nausea and vomiting. We still have it on the protocol here in our hospital and most hospitals. I don't think it's that important, to be honest, but regardless, probably keep your patient NPO for 2 hours is reasonable. Avoid caffeine and nicotine, and obviously that's for better heart rate control. And the same idea with cardiac cath, you hold them at 24 hours before and 40 hours after. Now, contraindication, I think that's quite important. Everyone should know about that. A very, very important contraindication is a patient is unable to cooperate with instructions. If you think for whatever reason your patient cannot follow in breathing instructions, please do not order a cardiac CT. It's going to be a useless study. We're just going to do it, and it's going to have zero diagnostic accuracy. As I'm going to tell you later on, breathing through the study is going to destroy the quality of the study. Obviously, patients should be able to lay comfortable for the brief amount of time that takes the hours to do the cardiac CT. Next, obviously, pregnancy, not a good idea to do a cardiac CT. Allergy to contrast medium. Another important one is, the renal insufficiency or history of contrast-induced nephropathy. You should pause if the creatinine is more than 1.5, and we tend to avoid it if the creatinine is 1.8, unless it's an extremely important test. Obviously, you shouldn't be doing cardiac CT in patients with a lot of active symptoms like shortness of breath, hypoxia, hemodynamically unstable, actively wheezing, and those kind of things. The allergy to beta blockers is not that important because, as you know, you can actually give calcium blockers, so that's not a big deal. A classic one that may be like kind of a trick question in the exam would be, a patient that just got sildenafil or tadalafil, and that's a problem because you cannot give your nitroglycerin. So that's not exactly contraindication. You'll have to delay the test, basically. Now, all right, you decided that your patient is appropriate for the test, and now it's coming at your scanner. What are the things that before you even start the scan is you have to get at least an 18 gauge IV. You need at least 18 gauge because that's the minimum that you need for an adequate injection. So having an IV, and we tend to prepare it on the right side, you avoid the strike artifacts, basically. Moving along, you have to consider about your beta blockers. We're going to talk to that in detail. Same about nitrates. Very important, explain the breathing instruction and stress them out to the patient. I'm going to stress it again and again to all of you guys that the patient needs to understand to hold their breathing during the active imaging acquisition. Otherwise, it's going to be a useless test. And of course, you put your EKG leads out of the field of view. Moving along, rate control. Rate control is quite important, and I will bring in your attention that the older the scan you have, the more important is the rate control. I will say that, here at the university, we are using the 4 scanners, which it's a very fast scanner. Our gantry rotation is very good. So essentially, you have a very good temporal resolution, and you can get away with a little bit, less than optimal rate control. Having said that, we still do rate control. And how do you do that? Well, you start the night before, actually. You give a little bit of metoprolol PO, usually 100 milligrams classic rule you end up giving. So the patient comes to the scanner and is already prepared. If they come there and they're still heart rate more than 65 to 70 beats per minute, then you can give some additional metoprolol and wait for an hour or so. We usually tend to give anywhere between 50 to 150, just to give you a general idea. 50 of metoprolol, you expect to improve your heart rate by 5 to 10 beats per minute. So, kind of do your math to decide how much you need to give. And then once you give your PO, you can give additional IV at the scanner there. But remember that you're kind of limited of the amount of IV you can give. The maximum is 25 milligrams. That actually comes from old studies on MI that you shouldn't be giving too much IV beta blockers. So that's kind of limited on the amount of how much you give. And that's why it's very important you give your PO even in the night before if possible. As I said before, if there is, for whatever reason, contraindication to beta blockers, you can actually use verapamil or cartisem. Either of the two is acceptable. And more recently, you can actually give ivabratin. To be honest, we don't tend to give ivabratin here. Even in I've never had issues with having adequate heart control if you use all of the above that I said. But again, it's an option and you can keep that in mind. And essentially, this slide here shows the importance of heart rate control. This is actually from 2010, so I think it's a 64-slide CT, so it's an old scanner. And essentially showing the same coronary artery. It's a curved MPR of the same coronary artery. On the far left, it has excellent heart rate control in the 60s. and everyone can agree that this is a pristine vessel. There is no question that this is a normal vessel, no questions, everything is looking great, right? So the middle one is have, more of an average heart rate closer to the 70s to 80s. And, you can probably still say that the coronary vessel is pale and no significant stenosis, but I can definitely, talk to you that there is maybe some mild non-calcified plaque around here, for example, whilst you see there's not much of a deal in the other one. And then here is, high heart rates in the 90s. This is essentially a non-interpretable study, right? So remember, heart rate control is important. Moving along, patient instructions. Breathing, breathing, breathing. Extremely important. Patient has to be able to follow up the command of holding the breath during the whole acquisition. All right, and classically, if they don't hold the breath, you're going to have a horrible quality image. And classically, exam, they're going to show you the example that you can see a horrible quality image, and then you're going to see misalignment of the sternum, basically, which is essentially going to tell you that there was breathing. It's not just breathing of the heart, which can happen either with a PVC or just motion artifact, but it's actually motion of the patient, either with breathing or actual motion of the patient. You should also tell them that, you should actually warn them that when they give the injection of the contrast, patient tend to do the Valsalva maneuver because of that weird feeling of the contrast, and that actually going to decrease the SVC flow, and that's going to reduce your contrast enhancement. All right. But again, breathing, breathing, breathing is the most important thing that the patient needs to be aware of. All right, moving along. Image, we're getting to the meat of this discussion, which is the image acquisition. And what are the things that you need to do in order? The first one is the tomogram, which essentially centers the heart in the field of view, and it's a give or take about 15 centimeters of field of view. Then you usually are going to do your calcium score, especially if your patient is greater than 45 years old, which is a gait acquisition. We're going to talk to that about later on, and essentially further defines the scan range and the calcium burden. Then you're going to give your contrast, and you can use either the test balls or the ball striking. I'm going to explain those two later on. Then you're going to do your cardiac CT angiogram. And then finally, if you're looking for a clot, you're going to do your 1 minute delays. Now, so this is generally your tomogram, which, as I said, is going to define your field of view. And this is going to be your field of view. As you can see, you start around right below the carina, and you go 2 centimeters below the diaphragm. Very important, very, very important. If you're going to be doing a cabbage case, you have to start high up, right? Why is that? Let's see, anyone. Why do you need to start high up if you're doing a cabbage case? Anyone, guys?
Yeah, you have to start high up so you can see the origin of the lima.
Absolutely, you need to see the origin of the lima, right? Yeah, I have to put your tips there. So obviously, and then the other thing is classically anyone that trains a little bit with a radiologist, and anyone that is going to go into advanced images, try to spend a little bit of time with the radiologist also. There is a lot of tips that you can get about imaging and about non-cardiac structures from radiologists. You have to always, when you're before doing your final report, it's not adequate just to take a look at your CT, right, for extra cardiac findings. You need to see your tomogram also, right? Why do you think it's important? It's very important that you see at least a quick look in on your tomogram, this view here. Why do you need to see this one? Does anyone have any idea for that? Because I can make an argument that what, I'm going to read the cardiac CT, so any extra cardiac findings, I'm going to look at them in the CT in much more detail. Why do I need to see this old picture of essentially a chest X-ray? Why is that the case? Anyone? So the reason for that is your field of view is this thing here, right? So the CT part that you're going to have is this part here. So you're going to see anything in the lungs here. But what about if there is, like, let's say, a cancer right here, right? You're not going to see that in your CT. So you definitely need to take a look, and there is all those horror stories that it was there and it was not picked up and it was missed. I've never seen one, to be honest, but you can see that there is the potential there. Moving along, calcium score. As you know, this is a non-contrast CT. We use slice thickness of 2.5 to 3 millimeters. It's a prospectively triggered scan, and we usually use the 40 or 70% phase. Essentially, if you have a good heart rate control, you use the 70% phase. If you have faster heart rates in the 80s, use the 40% phase. And the tube potential is always 120 kVs. That's important. Why? Because, you know, that was done on the initial studies with the when the Agatston score was derived. So that's why in order to use the Agatston score, you have to use 120 kVs. It's a problem nowadays because if you are using 120 kVs, as I'm going to explain later on, you're doing a lot of radiation. And nowadays you ended up having half of the radiation of the whole test is your calcium score, and the other half is the rest of the CT. And that's because of that 120 kVs in your top tube potential. Now, what is the advantages of the calcium score? So you minimize the scan range, so you can get a little bit of decrease in the radiation dose. Of course, as I explained before, you do an additional radiation if you do it to begin with. It does, I think the most important thing is this part here. It provides estimate of the plaque burden even before you even start the test. So that's good. And it's actually useful for general prognosis patient, especially in patients that you decided that there is no significant coronary artery disease, but they still have a little bit of disease. So, you know, there is a lot of papers that define prognosis in those type of patients. And it's going to give you an idea of how aggressive you are going to be with your medical management, even if you do not have obstructive coronary artery disease. And actually, this is, I'm going to do a quick pause here. I'm going to tell you one simple, it's not part of this test, but the big benefit of cardiac CT over any other functional testing is the following. In patients that they have no known coronary artery disease, you do a functional test and it's negative, right? It essentially tells you that the patient doesn't have obstructive coronary artery disease, right? Granted, with less sensitivity than the cardiac CT. If you do a cardiac CT, first of all, it's going to tell you whether or not there is obstructive coronary artery disease. But secondly, especially with the addition of the calcium score, is also going to tell you that your patient has mild disease. So that's not the cause of the symptoms, but you can take that information and use it to your advantage and treat the patient medically. For example, if I have a case of a 30-year-old female that came with some atypical symptoms, stress test, the exercise EKG was equivocal. I ended up doing a cardiac CT, which essentially showed that she had mild coronary artery disease. She had some, evidence of calcium in her coronaries. So in this patient, if you just did a functional test, you would just say, go home, there is nothing going on. But with the cardiac CT, I realized that, I have to put her on a statin. I have to focus on prevention. So, 10, 15 years down the line, it's not going to be that big of a problem. And that's one of the big benefits, actually, of the cardiac CT over the functional testing. Anyways, moving along, talking about the calcium score is also going to determine the pretest probability for obstructive CAD even before you go ahead to your cardiac CT. And then finally, an interesting thing is if you have very calcium score, sometimes people say 400 or some other papers say 600. Regardless, if you have high calcium scores, you should pause and think whether you should continue with your cardiac CT, right? Because if you have a ton of calcium, then you would expect a lot of blooming artifact, and you may not get an answer by your cardiac CT, and maybe a functional test would be a better option. So what you do in this case, you have to go case by case. So if you have a chunk of calcium that gives you like 600 calcium score and it's all located in your proxial AD, then probably you're not going to be able to define that. If it's more like all around in multiple vessels, you may be able to get around and give an answer. But if it's all located in the same location, a big chunk of calcium, that's probably going to be a lot of blooming artifact. You may not get an answer into that regard. Moving along, nitroglycerin should you be giving? Yes, the answer is absolutely. It has been proven from studies that it improves diagnostic accuracy. You usually give like 0.4 or 0.8. The peak effect is in around 5 to 7 minutes. Remember that you are not going to give it if your patient is hypotensive, obviously. And importantly, and especially for the test, contraindications would be severe aortic stenosis. And again, that's a very testable question. If the patient got a Viagra within 24 hours or tadalafil within 48 hours, right? Because you have longer half time. Contrast. That's important. Why? Because you always want to have a high contrast to noise ratio, because that's how you make your diagnosis. You want an intra-arterial opacification of at least 250 hertz per unit. We always use high iodine concentration, so it's kind of irrelevant at this point. Our injection is anywhere between 4 to 7 ml per second. Generally, for a typical size patient, you have 5 ml per second injection. As you can imagine, higher rate gives you an earlier peak and better contrast. However, you're actually limited by your IV size, and that's why you need that at least 18 gauge IV that we talked before. Your duration is usually about 20 seconds, 10 to get to the ascending aorta, and another 10 seconds for the scan. And what you end up giving, as I said before, you give for a typical size patient, you give 5 ml per second for 20 seconds. So you ended up giving about, give or take, 100 ml of contrast. Bigger patients usually tend to give 6 ml per second, and that gives you around 120 ml seconds. Nowadays, no one gives monophasic injection because you have the contrast stays into the pulmonary circulation. So what we end up doing, we give the injection, and then you give a saline chaser that actually mobilizes the contrast from the lungs, and you have a much better peak enhancement. Now, in our institution, and I think in most institutions, we realized that the right heart is actually, if you do a biphasic, it ends up being the right heart is a little bit wash out. So you actually see the LV very well and the coronaries very well, but especially if you want to get an idea of the RV, you don't see the delineation of the RV very well. So what you end up doing, you end up giving a triphasic injection, which is essentially contrast, then a combination of contrast and saline at the end, and that ends up giving you a little bit better right heart opacification without losing anything in the process. And then finally, a classic board question would be the patient with heart failure, how is that going to affect your contrast? Well, it's actually going to delay your enhancement, so it's going to take some more time to get there, but actually it increases your peak enhancement. Why is that? Because that low output, the contrast stays there, and it gives you better enhancement, and that's why you actually have a pretty good quality images in those 10 to 15% EF actually. Now, timing of the contrast injection, as I said, you can use either of the two, either test bolus or bolus tracking, and they are considered to be equal. So the test bolus, in our institution, we do bolus tracking, by the way. So test bolus, what you do, you give like a 10 ml of testing of contrast that is injected, followed by a saline of 50 ml. And then you have your sampling region created in the ascending aorta, and you're essentially measuring the time that is going to take for your test bolus from the injection to aggregate the adequate Hans-Mill unit in the aorta. So you measure that time, and when you do that, that actually gives you an opportunity to train your patient of what he's going to experience, so he doesn't do that Valsalva maneuver, and that does that acceptable breathing technique. And then once you do that, then you follow up with your actual injection, and then you just trigger based on the time that you already determined on your test bolus. In our institution, and most institutions are actually using the bolus tracking, where essentially at the same time you give your injection, you just have your region of interest in the descending aorta, waiting for the contrast to get to your pre-specified Hans-Mill unit. The older scanner had a Hans-Mill unit of 100. Actually, the faster scanner have much higher, more like closer to 200 Hans-Mill unit. And then once your contrast come to that level, you start your injection and you start your breathing technique at that point. And this actually from an older SCCT lecture showing how you do the timing bolus. So essentially, you have your axials in front of you while you're doing your test bolus, and you keep looking here, right? And you're measuring. So here you see there is nothing there. You keep waiting, nothing there, nothing there. You start seeing something here, then bam, you got here. So essentially, your delay time is your time from injection until you got here. So you have that time, and then you do your actual injection, and then you wait to start your actual imaging based on that timing. Whereas if you are doing the bolus tracking, what you do your actual injection, you have your measuring here the Hans-Mill unit. When you get your pre-specified Hans-Mill unit, you start your actual imaging. Moving along to the scanner settings, right? This is important, very relevant stuff for the exam at least. So just to give you an idea, so the three important things you need to know is the tube voltage, the tube current, and the mode. Now, tube voltage and tube current is actually very relevant for the exam, but at the end of the day, the newer scanner have actually pre-specified things that you just put based on your patient, the size of your patient, all that stuff, and then it has some automatic features, and they ended up being predefined, right? The mode, though, is something that you are going to decide for each case. So you're going to have a phone call with the, or you're going to be present at the test, and you're going to decide which mode you're going to do. So that's something you are going to make the decision on. Regardless, we still need to know about the tube voltage because the exam loves to ask about those things, and there are some important concepts that you need to understand. Now, what is the tube voltage? The tube voltage is essentially the energy content of the photons, right? And the higher your KVs, the more tissue penetration you have, right? So much more energy of the photons. You don't have any, essentially your photons don't stop while penetrating the tissue, right? So what gives you, and what's the benefit of that is gives you less image noise, right? However, think about it. If you have very high energy photons, and let's say that you give like super high doses, right? Then everything is going to pass, right? And then you're not going to have any contrast, right? And if you don't have contrast, it's everything is a plus or minus between what is the noise and what is the contrast. And you're trying to find what is the fine balance of less noise with a lot of contrast. So you need to give KVs, but you don't want to give too much that decrease your contrast too much. And I'm going to explain that more. Another extremely important thing that the boards love to ask is that the radiation increase exponentially when you give more KVs. And essentially it actually is proportional to the square root. The amount of radiation is proportional to the square root of the change in the voltage setting. And that's why that goes back to, you know, we give that 120 KVs in the calcium score. That's why it has all that radiation just by a simple calcium score, right? Now, as I was saying, you usually go weight-based. So generally most patients, normal size less than 90 kilos and a normal BMI. I'll tell you back, I don't know if that's most patients, but that's regardless. That usually you're going to give your 100 KVs. For bigger patients, you give 120 KVs. Some institutions, not in our institution actually, but if you have a very large patient, you know, more than 120 kgs or a BMI more than 40, they give 140 KVs. We don't do 140 KVs. We actually max our amperes and you do 120 KVs. And that goes to the fact that, you know, the KVs really increase your radiation. Now, going to the next thing that you need to be aware of, the tube current, right? So the tube current is actually the amount of photon flux, right? So the previous one was the energy, the tube voltage is the energy of the photons, whereas the tube current is the amount of photon flux, right? And so here is the thing, the more, the better is for the image quality, right? So there is nothing bad in image quality that is going to happen with more MAs, right? You give it and you have less image, and that's great, right? However, what's the downside is you have higher radiation. That's why you don't give a ton of it, right? Now, the thing to remember though is that the change in the radiation exposure is proportional to the change in the MA. So that's why in our institution and a lot of institutions nowadays, you prefer to go higher on the MA rather than going higher on your KV. Again, though, I will say that, you know, and again, your MA setting is anywhere between 300 to 800. You can always see it on the last page of your scan, actually. Again, the tube current is set based on the weight, and usually the newer machines pretty much put it automatically once you put the biometrics of your patients. And actually, a very nice feature of the newer scanners, they actually automatically change the MA with different projection. Obviously, you are doing a 360-degree acquisition. So the lateral gets more, they need to do more penetration, they increase the MA automatically. You don't need to do anything about it. They automatically increase on the lateral projections, whereas in the AP projection, they decrease a little bit, right? And then we're going to talk about that later. You can actually decide to do different MAs in different parts of the cardiac cycle. I'm going to discuss about this later on. Now, and all this all the things that I mentioned end up coming to what we think is the contrast to noise ratio, right? The ideal situation is this one here, where you have high contrast and little noise. So if you have this, so you want to see the difference between this structure and this structure here, right? So this is the line here and the line here, and they have this different contrast between the two, right? And then there is that noise. So if you have this high contrast to noise ratio, you're going to have this situation. You have this, and this, and as you can see, you can clearly identify the difference between the two. If you come to this situation where the contrast is less, but you still have a little noise, you can still probably be diagnostic, right? Or this situation that you have high contrast and high noise, you can still probably be diagnostic. But then the worst case scenario would be this one here, where you have high noise and low contrast, and you're essentially non-diagnostic. And then essentially, so again, I'm driving this to home, this idea, because it's a very testable idea. When you have your high KVP, it's going to decrease your noise, right, by increasing your tissue penetration, but it's going to decrease your contrast. So it's not all rosy, right? Plus the radiation, of course. Whereas the MA is going to increase your photon counts, it's going to increase your signal and decrease the noise. So essentially the MA it's never going to worsen your image quality. However, it's always a consideration, because increase your MA is going to increase your radiation. Finally, one important in the last part is going to be the scanning modes. Extremely important thing. That's something that you are going to decide every time at the scanner, or if they call you about the scan. Very important, with a lot of testable questions also. There is two types of scans that you can do. You can do the retrospective scan, the Helgal mode, versus the axial scan. And we're going to talk about both of them. So the Helgal mode, or retrospective imaging. What you do? Essentially, what you have, the X-ray tube is always on throughout the duration of the cardiac cycle, right? You have your scanner here, which is the gantry rotation that is doing like that. And then what is happening, the table is moving like that, right? So this is rotating, the table is moving, and you can imagine that this is rotating and it's table there rotating, and this is moving. So you can imagine that it creates a spiral through the patient. That's why it's called Helgal mode. And then you can imagine by that the detectors are not dedicated to a slice, right? Makes sense. And then your machine is going to interpolate and create a virtual axial slice, right? So it's not just an axial slice, it's just, interpolated one. Now, what is the benefit of that? Because you get all this information, I'm going to explain that you get overlap information. It's very flexible for your data processing. And if there's something wrong went to one part of the study, you can probably do an additional processing that gives you the answer at the end of the day regardless. And because you get all the images from the all part of the cardiac cycle, it gives you functional analysis of your patient also. What is the big downside? It gives much higher radiation exposure. All right. So always the big downside of that retrospective imaging is radiation exposure. It's actually like 10, we're talking about 10-fold radiation. All right. Now, whenever we speak about any Helgal scanning, you have to understand a concept, which is essentially the concept of pitch. So what is pitch? The pitch is your table feet for 360-degree rotation. So essentially how much time it takes for your, how much table feet you're going to do in the time that needs your gantry to do a 360 rotation, divided by your beam width, and your beam width is your coverage. So essentially your number of detectors multiplied by slice thickness, right? So essentially, if you're for a pitch of 1, essentially the table moves as much as your coverage, basically. So this is this situation here, right? So the table is moving, but throughout it moves just as much as it was your coverage here, right? And if you wanted to see here, it's going to be this situation here. So this is an old scanner that just have 4 channels here, right? And this is the width for each one of them. So if you do one gantry rotation, it's going to cover this up. So your table is only going to move that much. So within that time, it's going to go from here, and then it's going to go here. So there is no if it, in a pitch of 1, there is no data overlap, right? Now, on the other way, if you have a pitch of 2, the table is moving twice as fast as your coverage, right? So by the time that you're going to have one gantry rotation, you're going to divide, you're going to make gap in between, like in this situation here, right? Now, this might be okay if you're doing like a classic, CT of the chest, right? Because there are no moving structures and you can do a little bit of interpolation, right? On the other hand, if you are having a cardiac CT, you end up doing what you're doing here, a lower pitch. What is happening, essentially, your table is moving very slowly and you are having essentially data overlap. You see how those two are overlapping on one of the other? And while you're doing that, you're getting a lot of extra overlap of data. And why you do that? Because you need more data to make sure that you can actually get the best quality of the data. And just to give you an idea, in a cardiac CT, completely different from other type of CTs, your pitch is actually way below 1. It's usually like 0.4 or even lower. Now, you can imagine that that's going to give you a lot of overlap of data. Of course, it's going to give you much more information. And then through that, you're going to be able to, you have a wiggle room. If there is something wrong with that, some part of the information, you just exclude that and you get the good quality of the scan. However, that's going to come with the expense of the higher radiation exposure. So if you want to remember one thing, better quality imaging, much more information, but higher radiation exposure. Now, and that's exactly what I was just saying here, higher radiation exposure for 2 reasons, because your X-ray is always on, and then you have low pitch that is giving the data overlap and the oversampling. Now, there is an option that you can do something that we call tube current modulation, which essentially you tell to your machine that you take full radiation on the most essential part of the cardiac cycle, classically the diastole, and then you decrease your radiation during non-essential part of the cardiac cycle, let's say usually during systole. And that, if you wanted to see on an EKG, that's going to be your full radiation that you classically do, let's say, for a TAVR protocol. Whereas this one here, you see they do give full MAs during end diastole here, here, and here. Whereas you still take the images during systole, but on lower MAs. That would be a classic situation. Let's say I'm doing a cardiac CT, coronary CT on a younger patient, and that I also want to get functional data, right? So I use this part to get my coronary analysis, and then I use the overall part for the functional analysis, because for your functional analysis, you don't want too much details. You can get the LV function just by lower MAs, basically, right? And then by doing that, you decrease your radiation by as far as even 50%. Moving along to the prospective axial imaging, the one that you used to call step and shoot. So what do you do in this situation? Well, the images are acquired only during the pre-specified period of diastole, right? Look at here, you're looking your EKG. So your machine first starts just by monitoring your EKG, and it starts predicting where is your end diastole, right? And then when it does that, then it opens up only during these periods here, end diastole, right? So you are essentially, the machine is using the EKG to trigger the acquisition. During the other parts of the cardiac cycle, the tube is completely off. So no images at all here, off, off, off. Then it opens up here, gets image, close, gets image. And then you have a stepwise table movement, right? So what it happens, you are here, you get your image, right? Bam, then it closes down. The table moves. During the table movements, nothing happened. Then waits, then bam, gets another one, picks it up, another image here, and then moves, gets another image here, and you are done. And then it pieces them together and it gives you the images. Now, we don't tend to use the step and shoot images because, there is some actually newer scanners that they have that wide of coverage that just by doing one rotation, it can cover the whole thing. That's classically the Toshiba 320. It's actually the one that can do that. Our scanner actually needs to do 2 or 3 acquisitions to piece this up, right? Now, some considerations about the axial scanning. So first of all, as you have noticed, there is known data overlap, right? And because there is known data overlap, there is less margin for errors in your image acquisition, and there is less options for image reconstruction. So for example, if you happen, your EKG was monitoring, it triggered all those things here, but then there was a PVC somewhere here, then you are stuck. There is no option of getting that PVC out because you have limited information and you cannot bypass. It did happen to me a couple of weeks ago. Usually have experienced technologies that they call me and they do the scan again. In this case, for whatever reason it was missed, we have a PVC. We did all the amount of trying that we did, we couldn't do any data processing without avoiding that PVC, and you could ended up being the case that the scan was essentially uninterpretable. Anyway, other options is obviously you do not have functional data because you only have diastole, so there's no way that you could do that. A little bit longer scan time, so no big deal. So the downside is the main downside is this passage here. There's less margin of errors and then less option for image reconstruction and no functional data. But the big thing, and that's why you tend to do that most of the time, is that huge radiation decrease is up to 90% reduction. Because first of all, you are doing, it's only open in less amount of time, and there is no pitch or anything like that. What you need to remember is that you have to have strict patient criteria. So you have the patient to have a really slow heart rate and steady heart rate. It's not just to be slow, but it has to be steady also, right? And remember that if you, for whatever reason, your heart rate is not completely optional, it's still like, in 70s to 80 range, you can still do that axial scanning, but you do a little bit of padding. So essentially, instead of just doing end diastole, you don't just do like the 75%, you open it up a little bit. And sometimes what I do here is actually, I open it a little bit more up to the 40% the phase, because the 40% phase is actually the end systole, and that's actually a very good phase, especially for the RCA. So even if 40 to 80% phase, you still have a huge reduction in your radiation compared to your helical scanning. So it's a good option if you are not having an optimal heart rate control. You don't need to just do end diastole. You open it up a little bit, you do a little bit of end systole and then include end diastole, and you still save your patient a lot of radiation. All right. And just this slides here summarize all three of them. So this is your full retrospective that you have your MAs open throughout. Again, that's your classic TAVR protocol that you pretty much irradiate throughout. Then you have here the case, as I said, the patient that you want to do the coronaries here, but you want to get your functional study here, right? So you do your full study here, and then you decrease your MAs here. And then you have your axial, where you only have it open here, and you piece those together. And remember that if your scanner, for whatever reason, had a coverage that can cover the whole heart, then you just do one of them, and you don't need the other two, basically. All right? And with that, you are pretty much done with our lecture. That's a slide that I always include because a question that I get from all of our fellows always, what should I read about to get good in cardiac CTs and prepare for my exam? Again, that's completely my opinion here. You can use it or not. Some interesting things very useful things that I found when I was a fellow. There is the SCCT guideline paper. It's an old paper from 2015, I think. It's free in the website for SCCT. It's a must read, one paper. Then a very interesting thing that came out a couple of years ago, free on the SCCT website. There is actually what we call read with the experts. So there is I think 10 lectures that some experts in the field, I'm talking about probably some of the best well accepted in the field, like Dr. Leipzig, etc., that they have give excellent lectures of how to read actual studies. Very useful, I think, for any fellow that wants to start reading CTs. Then, of course, there is the SCCT board review course, which is extremely helpful, and I highly recommend it. There is the SCCT TAVR guideline paper that is also very useful and is also very testful in the exam. And finally, there is the one book that I use and I found it very useful is the cardiac CT book from Abramson. There is a number of books that you can use. This is just one that I use and I found very useful. All right. And of course, read as many CTs as you can. All right. With that, thank you for your attention, and I'm happy to take any questions.
Thank you so much, Dr. Christodoulidis. That was a fantastic lecture. Thank you for going over so comprehensively all the basics and advanced on protocols, etc. So thank you so much for making time on Saturday morning for giving this lecture. Let me check. Dr. Ashra, do you have any questions for Dr. Christodoulis?
Is it okay to just ask questions as opposed to type them?
Yeah, please go ahead.
Thank you very much. So thank you for the excellent and very comprehensive lecture. My question is, sometimes you get patients where they have a contraindication for invasive coronary cath, like they have a known dissection of their ascending aorta. And so the surgeon will ask for a cardiac CT, even though they're not an optimal patient for a cardiac CT, like they're elderly, they have a high calcium score, or they have a fast heart rate, which again, because they're in cardiogenic shock or some element of heart failure, you really don't want to load on too much beta blocker. How do you prep these patients to try to get as much information as you can from the study?
So, obviously, so you just to make sure I'm getting your question right. So you're asking that you have a patient that you, for whatever reason, you cannot give beta blockers, basically, and what can you do for getting more information? Is that the question?
Or yeah, exactly. Or you can't, maybe just very, very limited amount of beta blocker. Like you have to be very careful with how much beta blocker you're giving.
Sure. All right. So a couple of things. So the one thing that comes to mind, although I haven't done it, you can use ivabradine, right? So that actually brings down the heart rate without that much of an effect on the blood pressure. So that's one option. Other option, unfortunately, there's not too many things that you can do in regards of controlling the heart rate in another way. So ivabradine is the one thing that I can think of. And hopefully, I will say the following though: if you have a good scanner, so essentially talking about the good in regards of with good temporal resolution, the FORCE scanner is actually an excellent scanner in that regard. You can actually get very good quality studies in even in heart rates in the 90s, right? And the one thing that you definitely want to do, you should probably, in this case, you should probably do a retrospective study, or at the very least, make sure that you include end systole in your scan. Why is that the case? Because the end systole is actually a very good phase in high heart rates. I will tell you for a fact, in our institution, I have, as long as the heart rate is regular, so that's important. If you have a regular heart rate, even in the 90s, if you have end systolic phase, you can get excellent quality studies. There is actually specifically, some studies from Mass General, and that they actually presented that a couple of years ago in the SCCT, that specifically they are using the FORCE scanner, but I think can be extrapolated in any scanner with good temporal resolution, that they had excellent quality studies without giving any beta blockers. But the trick here, it has to be a regular heart rate. And if you don't have that, then probably I would do a full retrospective scan and hope for the best, and then consider ivabradine if that's a possibility.
Thank you so much.
Thank you, Dr. Christodoulis. There's a question in the chat for you. How about patients with pacemaker to control heart rate? How do you approach patients with pacemaker?
So I'm trying to understand what is the question. So essentially, if you have a pace rhythm in the 70s classically, right, that should not be a problem actually. So because it's a very regular rhythm, I don't tend to do anything actually in that regard. It's a regular rhythm. It's generally, you don't have someone pace in the 90s, obviously, right? So if you have, for whatever reason, in some rare cases, and I've never had the situation that I had to scan a patient like that. In some rare cases, you have someone that is pacing pretty high heart rates. I guess in that case, you can probably discuss with the P and then briefly bring the heart rate down for the time of the scan. Anytime that I had a pace patient, it was usually in the 70s. And that was not a problem to get a pretty good quality scan actually, because it's a very regular rhythm. So remember, the heart rate is two parts: how fast it is and how regular it is. So a regular heart rate in the 70s is generally not a problem for a good scan acquisition.
I presume it's probably easier to scan these patients because you can give beta blocker more safely, and they're more likely to have a regular rhythm.
Yeah, no, there's no question about it. But generally, I mean, if it's in the 70, I don't even get into that because it's again, it's a regular rhythm, so it's not really affecting you.
Yeah, sounds good. Dr. Ashra, do you have any questions or comments?
Yeah, I think that was, sorry. I think that was a great review. Thank you very much, Georgios. That was very comprehensive and, that was excellent. Thank you very much for doing this.
Sure. Thank you for inviting us, and thank you for doing all that hard work and putting
Thank
this
you.
together.
Yeah, I have the Fit Council behind me. They have been the force behind me along with our chapter executive. But, without speakers like you, we couldn't do this. So thank you again. So I'm going to just briefly share my screen for a second. So I just wanted to, show that we have this upcoming lectures here, 2022 Fit Echo Boot Camp that we are trying to do along with Minnesota ACC chapter. This is going to be four sessions, 6 to 8 p.m. in July, but we're also going to be continuing along with that. But probably once a month session. More details will be posted soon about that. Again, that is between us and Minneapolis ACC, and it's going to be directed quite a bit by the Mayo Clinic. Dr. Marcus from Iowa is going to be doing these 4 sessions. So there is a registration link on our website. If you or your peers or your colleagues or, especially the incoming fellows, if you have an interest, this is going to be covering most of the basics. So, just wanted to share that. Also wanted to share that, all the recordings from these lectures will be uploaded or being already uploaded to this, the Iowa ACC website under fellow education. So this is where all the education links are. This is the board prep lectures, interventional echo, but this is also the advanced imaging. So thank you all for joining all these lectures, and I hope you're enjoying them. Without further delay, I'll move on to introducing our next speaker for today, Dr. Monica Mukherjee. Dr. Mukherjee is an adult cardiologist and an associate professor of medicine at the Johns Hopkins University Division of Cardiology, and she specializes in advanced cardiac imaging. She serves as medical director of the Echo Lab at Johns Hopkins Bayview Medical Center and also as the director of echo research across campuses. Dr. Mukherjee graduated summa cum laude with a dual bachelor's of science in psychology and behavioral neurosciences from the University of Florida. She received her doctorate in medicine from George Washington University in Washington, D.C. and internal medicine residency at Drexel University before returning to George Washington to complete her fellowship in cardiovascular disease. She has an MPH from the Johns Hopkins Bloomberg School of Public Health with a special concentration in epidemiological and biostatistical methods for public health and clinical research. Dr. Mukherjee has an accomplished academic career with multiple research awards focused on right ventricular remodeling in heart failure, pulmonary hypertension, and scleroderma. She was the recipient of the 2020 Johns Hopkins University Clinician Scientist Award and also has been funded by the NIH, the Scleroderma Foundation, and the CHEST Foundation. She was awarded the Top 25 Young Investigators Award from the ASC in 2026. And I'd like to thank Dr. Mukherjee for taking time out of her busy schedule, and she's going to be talking to us about multimodality imaging in pulmonary hypertension. Thank you very much, Monica, for doing this.
Thank you, Dr. Ashwat. Hi, everyone. Happy Saturday. Lovely to join you virtually. I will be speaking on multimodality imaging in pulmonary hypertension, and I do not have any relevant disclosures. So the objectives for my talk today will be to define new updated classification of pulmonary hypertension using the 2019 guidelines. We will review the 2015 American Society of Echo chamber quantification guidelines, specifically as they relate to right ventricular chamber size and function. I hope to establish the role for novel echocardiographic applications to detect abnormalities in RV function and contractile reserve. And then we will review multimodality imaging techniques and applications in PH, as well as describing the importance for CMR in tissue characterization. So since the first World Symposium on Pulmonary Hypertension in 1973, pH has always been defined as a mean PA pressure of at least 25 millimeters of mercury. However, during the 6th Congress, the task force members actually suggested that this definition be changed to a mean PA pressure of greater than 20. And the authors based this recommendation on the fact that the original definition was chosen somewhat arbitrarily and didn't really represent the upper limit of normal. And since that time, there have been a number of important epidemiologic studies, including a study out of the VA that determine that patients who fall into this intermediate range of 21 to 24 are actually at a great risk for developing overt PH within a 5-year period of time. And so for that reason, in 2019, the mean PA pressure of greater than 20 millimeters of mercury at rest is now the new definition for pulmonary hypertension. And one of the biggest constraints and common diagnostic problems in PH is the distinction of PAH from pulmonary hypertension due to left-sided heart disease or post-capillary PH. Pulmonary hypertension is classified on whether or not it occurs pre or post-capillary bed. So the first category is group 1 pulmonary arterial hypertension, which is the vast minority of patients. And these are patients with idiopathic, connective tissue etiologies, HIV. The second pre-capillary group is actually group 3, which is pulmonary hypertension due to lung disease, chronic hypoxia, OSA, OHS, COPD, ILD. Group 4 is chronic thromboembolic pulmonary hypertension or pulmonary artery obstruction, and the prevalence and incidence of this is likely greatly underestimated. So it's only 0.6, but again, that's probably an underestimation. And then group 5 is pulmonary hypertension with unclear or multifactorial mechanisms. So sickle cell anemia is a common one here. And then the vast majority is pulmonary hypertension due to left-sided heart disease. So LV systolic or diastolic dysfunction, valvular heart disease, such as severe MR, congenital diseases as well. And it's important to recognize that pulmonary arterial hypertension can really only be diagnosed in the absence of significant obstructive or restrictive lung disease. The subcategorization and method for detecting PH is done invasively with right heart catheterization. So again, pre-capillary PH, which is group 1 and 3 through 5, is defined as a mean PA pressure of greater than 20 with a wedge of less than or equal to 15. Post-capillary PH is group 2 disease or PH secondary to left-sided heart disease, and can also include group 5 if there's mixed or unclear etiology. And then to distinguish whether or not this is isolated post-capillary or combined pre and post-capillary, you use the diastolic pulmonary gradient, which is defined as the diastolic PA pressure minus the mean wedge pressure. And this is felt to be less influenced by a wedge at any level of stroke volume. In normal subjects, your diastolic pulmonary gradient should be between 1 to 3. PH or pulmonary hypertension of any etiology should really be suspected in patients with otherwise unexplained shortness of breath, syncope, or signs of right heart dysfunction. And the number one first methodology for screening is actually echocardiography. And so with that, we will go ahead and review the guidelines and standards from 2015 American Society of Echo. Screening for PH using 2D echocardiography relies on both morphologic and hemodynamic assessment in accordance with these guidelines. Morphologic assessment begins with looking at linear dimensions of RV chamber size. So to look at the RV, you really want to make sure that the transducer is moved laterally in the apical forechamber to make sure that the free wall is visualized in both systole and diastole. And then the basal RV linear dimension is that maximal transversal dimension in the basal 1/3 of the RV inflow at end diastole. The mid-cavitary RV dimension is the transverse RV diameter in the middle 1/3 of RV inflow. And then the longitudinal dimension should again be the apex traversing the tricuspid annular plane. So if your apex is actually shifted leftwards, that is the true apex. Dimensions can also be obtained from the left or sternal window. So you can obtain the distal and proximal diameter of the mid RV. So the RVOT proximally can be measured from the peristernal long or the peristernal short at the level of the aortic valve. And then the distal RVOT is measured at the pulmonary valve annulus. And here are the reference dimensions. Lastly, you can either look at the subcostal or the left peristernal window to measure RV wall thickness, and that should be 0.5 centimeters from either window. Next, you can trace the right atrium to obtain minor and major dimensions, again from the apical forechamber, as well as volumetric and area dimensions as well from this view. So RA dimensions and area are obtained from the apical forechamber and ventricular systole, from lateral to septal aspects of the tricuspid annulus along the interatrial septum and the superior aspect of the right atrium. And similar to LA volumes, RA volumes are really not sensitive measures to acute changes in filling pressure. So you can see a dilated RA in patients that have normal RV filling pressures, like athlete's heart or left to right shunt. And RA volumes are really a better reflection of chronic changes of RV filling pressure. So it is a poor prognostic sign if you see a severely dilated right atrium. It's an indicator of underlying RV diastolic dysfunction and, again, chronic elevation and filling pressures on the right. Next, the interventricular septal morphology should be assessed from the parasternal axis at the level of the mitral and/or papillary muscles. The magnitude of intraventricular septal flattening can be quantified using the eccentricity index, which is defined as the ratio of the length of two dimensions, so the LV anterior posterior and septolateral dimensions. In normal hemodynamic states, this ratio should be about 1 in both systole and diastole, reflecting a roughly circular contour of the LV throughout the cardiac cycle. An eccentricity index that's greater than 1 at end diastole is suggestive of RV volume overload, whereas a value of greater than 1 in end systole and end diastole can indicate the presence of RV pressure and volume overload. The next step in the comprehensive evaluation of the right heart is functional assessment. So fractional area change is a measure of RV systolic function that correlates well with RVEF by cardiac MRI. Fractional area change is obtained by tracing the endocardial border, again from a modified four-chamber view, making sure that the lateral wall is fully visualized in both systole and diastole, and tracing the chamber in end diastole and end systole to make sure that you are excluding any trabeculations in the moderator band. While FAC calculates a volumetric or area change that's similar to LVEF, RV function, unlike the LV, can also be assessed looking at longitudinal measures of function, including TAPSE and tissue Doppler S prime peak velocity. So TAPSE, of course, is the tricuspid annular plane systolic excursion. It's a mouthful, and that's a method to measure the distance of systolic excursion of the RV annular segment. So this is acquired by placing an M-mode cursor through the lateral tricuspid annulus and measuring the amount of longitudinal motion of the annulus at peak systole from the apical forechamber. And lastly, tissue Doppler S prime is acquired by placing the tissue Doppler cursor sample along the lateral tricuspid annulus again and assessing peak systolic velocity. And again, this is another measure of longitudinal motion only. However, the pitfall of tissue Doppler is similar to any Doppler-based measure where you can really underestimate the annular velocity if the interrogation plane is not exactly parallel to the plane of motion. And why that's important is that one of the initial signs that we see in RV remodeling is known as ventriculo-arterial uncoupling through a phenomenon known as apical traction. So the predominant vector of contraction of the RV is along the longitudinal plane. And that's because of the longitudinal predominant fibers within the endocardium. And so when the RV becomes weakened, the LV forces can tether the RV apex leftwards. And as such, you can develop this phenomenon known as apical traction, where again, the RV apex is kind of shifted leftwards. And that speaks to the RV free wall actually being quite weak. So any measure of longitudinal function, whether it's tissue Doppler S prime or TAPSE, can actually be normal, and even in cases of apical traction where the RV is probably weak. And that's certainly what exists in this case, where both TAPSE and tissue Doppler were normal, but fractional area change was mildly reduced. And apical traction, again, is one of these early signs of RV maladaptation to emerging pH. In animal models, the RV really functions as an end organ mechanistically. Hypertrophy is the initial adaptive response to an increase in RV afterload. In order to increase contractility, there is an increase in tissue thickness and mass by means of circummerogenesis, again along a longitudinal plane. But with sustained pressure overload, the contractile increases are simply insufficient to maintain cardiac output. And what happens over time is that there's progressive chamber dilatation. So there's an increase in the RV chamber internal radius in an effort to increase cardiac output and RV ejection. And what's known as sphericalization of the RV free wall, which is the change in the ratio of longitudinal to circumferential length, is associated with heart failure and ventricular arterial uncoupling. And here we see an echocardiographic example of ventricular arterial uncoupling characterized by massive RV enlargement, intraventricular eccentricity index that's consistent with RV pressure and volume overload. There's a small deremodeled LV, massive right atrial enlargement. And even here you can see that the interatrial septum is fixed from right to left, suggestive of elevated right-sided feeling pressures in a 66-year-old woman with connective tissue disease associated group 1 pulmonary hypertension. You can also use echocardiography for quantification of regional and global myocardial function using two main techniques, either tissue Doppler or speckle tracking based strain. Both of these techniques provide comparable data quality, although tissue Doppler is known to be relatively angle dependent. And so speckle tracking has really emerged as a preferable technique where an offline software can be applied either in real time or to previously acquired 2D images. Optimally, these images should be acquired at 40 to 80 frames per second and can really provide detailed information on regional and global deformation. So speckle tracking technology is simply based on ultrasound and tissue interactions. As the ultrasound beam hits the myocardium, pixels or speckles are generated within the myocardium from random reflection, refraction, and scattering of the ultrasound beam. And then during offline analysis, here in this example, this is of the LV, you're tracing the endocardial border from this apical forward chamber beginning at the medial mitral annulus along the inferoseptum and anterolateral wall. And then the software will track the speckles frame by frame using a mathematical algorithm. Each segment in the image that you're seeing corresponds with a color-coded strain. And the white dotted line here is an average of all of the segments seen in this view. For the LV, this is taken from the apical 4, 2, and 3 chamber, and from the RV, just from a modified apical 4. And so here the strain curves correspond with the onset of ventricular systole. Then the strain becomes more negative, peaking at aortic valve closure and isovolumetric contraction. Then we see the onset of diastole with a less negative strain curve, as well as isovolumetric relaxation and your peak diastolic relaxation velocity. And these same techniques, again, can be expanded to the RV free wall with or without inclusion of the intraventricular septum. Now, systemic sclerosis is a very common cause of group 1, 2, and 3 pulmonary hypertension. It's an autoimmune disease that's characterized by heterogeneous phenotypes because of differences in how widespread the fibrosis is and involvement of multiple organ systems. It's traditionally characterized by a prominent vasculopathy, dysregulation of the immune system, and a common association with Raynaud's. And again, survival rates are strongly dependent on the degree of organ involvement. It's a relatively rare disorder, but it's getting less rare. There's a strong female predilection, 4 times greater than men. Women present most commonly in the 4th and 5th decades of life. And the age and gender adjusted mortality rates are 5 times greater than a normal population. And echo can be very useful in pulmonary hypertension, especially in connective tissue disease pulmonary hypertension, because all of the metrics that I just described, whether it's fractional area change here, RA size, M-mode-derived TAPC, the eccentricity index, of course, hemodynamic assessment can all be used in pulmonary hypertension. So Right atrial and RV chamber enlargement is actually related to onset of heart failure and mortality in systemic sclerosis. Echo measures of RV contractility all correlate with diminished survival in systemic sclerosis related PH, and non-invasive measures of PVR actually are predictive of avert PH and correlate well with 6-minute walk and DLCO. And why I'm highlighting scleroderma is this disease state is an example of where RV deformation imaging or speckle tracking strain of the RV can actually be quite useful. So in this study, we applied speckle tracking techniques to the RV free wall. And what we found was that despite having a normal TAPC, these were all patients that had no overt signs of RV failure or known pulmonary hypertension. There was this very unique pattern of basal strain. And I'm sorry, the arrow should be a little bit further down here to highlight that the basal strain was actually hyperkinetic early on in the disease course in scleroderma, while there was relative hypokinesis of the mid and apical segments. And then when we applied the same techniques to scleroderma patients versus idiopathic pulmonary hypertension patients, we performed echocardiography within an hour of right heart cath. And what we see here is, despite relatively lower pulmonary pressures in the scleroderma group, there is a similar degree of cardiac dysfunction as defined by cardiac index. We also saw that the 1 and 3 year survivals in scleroderma PH was severely diminished in comparison to idiopathic PH patients, even though the scleroderma patients had relatively lower afterload. When we looked at the echo of these same patients, what we found was that at similar loading conditions, the strain in scleroderma patients was much worse than the idiopathic patients, and it was driven by loss of this basal strain. And when we then gave these patients 36 weeks of combination therapy with ambrisentan and tadalafil, there was significant improvement in global strain driven by improvement in basal strain. So taken together, these findings suggest that basal strain is a very important marker for screening, detection of therapeutic response, and prognostication in group 1 pulmonary hypertension, and especially those with connective tissue disease. And subsequent studies have actually demonstrated that RV strain with or without inclusion of the intraventricular septum is highly predictive of 4-year mortality, where a strain of less than 13 correlates with diminished survival. We also can use strain coupled with exercise stress echocardiography to provide key prognostic information in scleroderma patients who are at risk for PH. So beyond looking at changes in mean PA pressure during exercise, which actually probably result from a complex interplay between RV contractility and afterload, we can actually use strain as a measure of functional reserve. So in this study, what we did was we did supine bicycle echo with strain, and we again saw that there was this heterogeneous regional contractility with relative hyperkinesis of the basal segment and hypokinesis of the mid and apical segments. However, with exertion, if there was an associated delta change in RVSP of 20, none of the segments increased with exercise, and the chamber began to dilate, a sign of ventricular arterial uncoupling. However, in patients who did not have a delta change in their RVSP of 20, the mid and apical segments actually were able to augment appropriately, similar to normal controls, and the basal segment really didn't change in either group. And so these findings alone suggest that we can couple strain with exercise to determine who is at greatest risk for developing overt pulmonary arterial hypertension. Lastly, of course, echo can be used for hemodynamic assessment. So we all know RVSP is calculated by 4 times the peak TR velocity squared plus the right atrial pressure. In this example, the TR velocity is 3.8, which is around 58 plus whatever the right atrial pressure is. We can also calculate the PA end diastolic pressure, which is 4 times the end diastolic PR velocity. This is a direct correlate of PA diastolic pressure and an indirect correlate of LV-EDP. In this example, it calculates to 26 plus whatever the right atrial pressure is. And then there's a number of ways that we can calculate mean PA pressure non-invasively. And lastly, we can also use echo to calculate PVR. So this is known as the Abbas formula. It's the peak TR velocity divided by the velocity time integral across the RVOT times a factor of 10 plus 0.16. However, the ability to calculate hemodynamics non-invasively is again highly dependent on the presence of an analyzable Doppler signal. We've all seen examples such as this, where there is severe right ventricular enlargement, ventricularization of the atrium, laminar flow across the tricuspid valve. And so over 90% of TR that we see is due to functional etiologies, including left-sided valvular heart disease and PH, where there's significant dilatation of the tricuspid annulus resulting in an incompetent valve. And here we see a really classic example of functional TR. And the Doppler signal is dense and triangular in shape, early peaking. Here it's 1.4. So again, this is consistent with severe TR and an RV pressure that's similar to the RAV wave. And in these cases, hemodynamics, of course, will be significantly underestimated. And lastly, hemodynamics and with the behavior of the IVC from the subcostal imaging plane at an expiration, using a cutoff of 2.1 for the diameter and looking for collapsibility with respirophasic variation. And again, this would not be an accurate reflection in ventilated patients that are on high PEEP. So key points of how to use echocardiography for assessment of pulmonary hypertension. Of course, there's hemodynamic assessment. You also want to perform comprehensive morphologic evaluation, looking for abnormal chamber size and function. I would consider strain, especially in group 1 pulmonary hypertension, as this can be prognostic. And then, of course, the presence of abnormal regurgitant lesions. Chest CT is also integral in working up pulmonary hypertension, and especially in those who you are suspicious of group 3 disease. So here we see computed tomography images of the chest with and without contrast from a 64-year-old woman with connective tissue disease and severe ILD. This is a patient with mixed severe pulmonary hypertension, as evidenced by enlargement of the PA as well. There's no evidence of a PE here. And so the presence of lung disease plus abnormal pulmonary function test, CT findings, as well as a PA pressure of greater than 20 with a wedge of less than or equal to 15 is strongly suggestive of group 3 pulmonary hypertension. The diameter of the main PA compared to the ascending aorta is also another metric that we use in looking at these patients. So in the Framingham Heart Study, a mean PA diameter of greater than 29 millimeters correlated with elevated mean PA pressure with its sensitivity and specificity in the 80s. And then you can also look at the ratio of the mean PA pressure to ascending aorta, where greater than 1 correlates with an elevated mean PA pressure with around 70% sensitivity and specificity. However, the main PA can also be enlarged in fibrotic lung disease. So that really confounds the use of CT for screening of PH. CT has not been shown to be predictive of PH in isolation as accurately as echo and CMR, but its sensitivity and specificity increases when you are using these in combination with other modalities. And then there's a newer technique known as dual energy CT. So this is a technique that acquires CT angiographic images of the pulmonary vasculature at 2 different energy levels after administration of IV iodine-based contrast. So due to the different attenuation properties of the iodine contrast at these 2 energy levels, the quantity of the iodine left within the pulmonary vasculature can serve as a surrogate for pulmonary perfusion, and it can be measured. So the amount of pulmonary perfused blood volume, which is known as PBV, can be qualitatively and quantitatively used to screen for pH. Patients with PH will have a mosaic attenuation of this pattern due to dysregulation of the pulmonary vasculature. and both the total degree and quality, as in whether or not there's the presence of mosaic attenuation, to main PA, that ratio also correlates very well with mean PA pressure. So again, in a patient with abnormal hemodynamics, when you're looking at CT, you can compare the main PA artery diameter to the ascending aorta. CT is required for evaluation of the lung parenchyma and to rule out group 3 disease. You also want to administer with contrast to assess for acute or chronic thromboembolic disease, as in what would be seen in group 4. Next, we'll move to ventilation perfusion scanning. So again, CTEPH, or group 4, is a disease of obstructive adverse pulmonary arterial remodeling as a consequence of major vessel thromboembolism. And like I mentioned before, it's really hard to estimate the cumulative incidence. Reports vary from anywhere from 0.1 to 9.1% within the first 2 years after symptomatic PE. And really, we don't know what the actual numbers look like. It is very much an underappreciated disease, and that's because after patients present with an acute PE, we rarely are getting subsequent imaging until years later when they present with pulmonary hypertension. However, PA thromboembolism and chronic vessel obstruction lead to progressive increases in PVR. So to make the diagnosis of CTEPH, the diagnosis is after 3 months of effective and adequate anticoagulation to discriminate this condition from subacute PE. It's again defined as a mean PA pressure of greater than 20 with a wedge of less than or equal to 15 and mismatch perfusion defects on VQ scan and specific signs of CTEPH by CT angiography, MR, or pulmonary angiography. And VQ scans have high sensitivity and specificity in the diagnosis of CTEPH, outperforming CTA alone. You can also use nuclear medicine techniques to look for increased stress on the right heart. So in PH, you can have an increase in myocyte glycolysis that is appreciable by FDG PET. And then hybrid PET and MR imaging has also demonstrated that a combination of RV ejection fraction and adverse tracer uptake within the RV is associated with clinical deterioration or PH. So again, in looking at SPECT imaging, how this is applicable in pulmonary hypertension is again using VQ scan in the diagnosis of CTEPH. And then you can also see increased FTG 18 PET uptake in the RV and the PA in chronic forms of group 1 pulmonary hypertension too. However, CMR is really the reference standard for how we assess RV structure and function in pulmonary hypertension. It has an exceedingly high reproducibility in the measurement of RV volume and mass and ejection fraction. It can be used to quantify regurgitant volumes, assess for tissue characterization. And in a recent study, native T1 values of the interventricular insertion regions were evaluated in different types of PH, including idiopathic, group 1 pulmonary hypertension, connective tissue disease-related pulmonary hypertension, and chronic thromboembolic disease. And was shown that in precapillary forms PAH, native T1 mapping will show this very predictable increase in values at the interventricular insertion sites, and it correlates well with disease severity. When we're looking at CMR, and especially in patients who are on PAH-directed therapies, you really want to be able to quantify volumes in 3 dimensions. So echo is limited by the complex geometric configuration of the heart, and you really cannot see the contribution of the RV inflow and outflow using 2 dimensions alone. And for this reason, cardiac MRI, especially when you're monitoring therapeutic response, is very important for measurement of RV volumes. And you can also quantify global RV function across 3 coordinate directions: circumferential, radial, and longitudinal. So speckle-based strain using echo only measures longitudinal strain, while CMR techniques, either using dedicated sequencing such as strain-encoded CMR or SANC, or post-processing using feature tracking or tissue tracking, can measure global RV function across circumferential and radial planes as well. Strain-encoded MR is based off of the acquisition of two images with different frequency modulation, so low tuning or high tuning in the slice selection direction that represents static versus contracting tissues. And then lastly, CMR is highly important in pulmonary hypertension because it allows for tissue characterization. So in scleroderma and other connective tissue diseases, understanding to what extent ischemic injury or inflammation is contributing to myocardial damage versus fibrosis is needed to define proper treatment and prognostication. And it can also help to identify those patients who are at the highest risk for cardiac deterioration. So using, again, systemic sclerosis and connective tissue disease as an example, scleroderma patients will frequently have late gadolinium enhancement in a non-coronary distribution with or without abnormalities in LV or RV size that may not be apparent by 2D echo alone. And so CMR should really be considered in connective tissue disease patients that have early aggressive disease, PVCs, and in those with mild persistent elevation in their cardiac enzymes. CMR can also detect low-grade inflammation and diffuse myocardial inflammation through native T1 mapping and extracellular volume quantification. But it's important to clarify that although CMR can detect myocardial inflammation, it cannot distinguish etiologies such as infective versus autoimmune myocarditis as an overlap syndrome. CMR can also be used, of course, using late gadolinium enhancement to look for fibrosis. So late gadolinium enhancement is the gold standard for in vivo assessment of replacement macroscopic fibrosis. And CMR can detect fibrosis in less than 1 centimeter cubed of tissue with excellent histologic agreement. In connective tissue diseases such as scleroderma, there is late gadolinium enhancement and interstitial fibrosis that can be detected by LGE techniques. CMR can also be used for perfusion imaging. So previous studies have demonstrated that there is a circumferential loss of perfusion within the subendocardium in scleroderma patients, suggestive of ischemia due to microvascular disease. And lastly, biventricular perfusion is significantly reduced in group 1 pulmonary hypertension and correlates well with mean PA pressure. CMR flow and PA vasoreactivity can also be obtained. So looking at 2D and 4D flow characterization through the RV is a relatively novel technique to investigate the hemodynamics of the RV and the PA. The reduced PA blood flow velocity correlates with a high PVR. These patients also have diminished PA defensibility, which is also predictive of mortality. And then there's something called vortex imaging. So you can see greater retrograde blood flow through the PA in PH, and the length of that vortex also correlates with mean PA pressure. And then lastly, you can also use 3T MRI with isometric hand grip, which is a well-established endothelial dependent stressor. And what we see is that patients with PH actually have abnormal pulmonary artery vasoreactivity. We've shown this in HIV PH patients compared to normal controls. And here we see CMR images from a 38-year-old woman with idiopathic group 1 PH. Here we see a 4-chamber bright blood CMR image and end diastole with a dilated and hypertrophied RV. This patient had a mean PA pressure of 50. The end systolic images actually show that there is leftward bowing of the interventricular septum from elevated RV pressures. We also see here this late systolic images that I just described. Here's a short axis view of the CMR with marked hypertrophy of the RV free wall. And again, this abnormal septal bowing or eccentricity index, and then prominent enhancement of the anterior and inferior RV insertion points. So CMR in PH is highly useful for measurement of right heart size and function. Abnormal tissue characterization can also be used for perfusion imaging. and study of vasoreactivity of both the RV and the PA. And so in conclusion, I hope that I've demonstrated to you that echo, CT, nuclear, and CMR are all useful in different ways for non-invasive screening, classification, prognostication, and monitoring effectiveness of therapy. Right heart cath is the gold standard in the diagnosis and monitoring, but it can really be supplemented by these non-invasive imaging modalities to ensure that it is being selectively and appropriately used. And we do know that earlier detection of PA and RV dysfunction using these common imaging modalities can lead to earlier diagnosis and treatment of PH, which has been shown to improve clinical outcomes. And again, the mainstay in diagnosis is utilization of echocardiography to guide suspicion and to guide further diagnostic testing. And so with that, I will end and take any questions.
Thank you so much, Dr. Mukherjee. That was a comprehensive overview of multimodality imaging in pulmonary hypertension, certainly very high yield for our fellows. So we appreciate you taking time out to talk to us today. So one question I have actually from my own like recent clinical experience. So, was seeing a patient in clinic who had a recent some massive PE that was managed with thrombolysis. And the initial echocardiography showed pulmonary hypertension, some RV strain and RV failure, but clinically patient was doing okay. So question is there a role for like multimodality imaging early or on subsequent follow-up to identify like high-risk patients who are at risk of C-death, and what is your approach?
Yeah, so that's a great question. And I think it ties into this question that Dr. Pasupula has, where, if your suspicion is high, you certainly should image these patients within 3 months of adequate anticoagulation, and they should be followed, and certainly within 6 months. I think 3 months may be a little aggressive if it was a massive showering of PE everywhere, but certainly within 6 months, they should be imaged again. And most often the PA pressure should, so I don't know if you've ever heard of the 60-60 rule, but the PA pressure should not reach 60 in acute PE alone. And if you really are having severe elevation in your PA pressure acutely, it signifies that there's some sort of chronicity underlying that PA pressure elevation. Acute PE alone shouldn't cause that degree of obstruction or pulmonary elevation in your PA pressures.
Sure, no, that's very useful. So with the new guidelines having a new cutoff as far as invasive hemodynamics for the pulmonary hypertension, what number should get you suspicious of pulmonary hypertension on echoes?
So it's a great question. We're actually working on an updated guideline to answer that. So in all of the screening algorithms that we currently use for PH, the TR velocity cutoff is 2.8, which corresponds with, a PA pressure of, or an RVSP of 35 at best. But my own practice is I basically say 35 to 40 is top normal, 40 to 50 is mild, 50 to 60 is moderate, greater than 60 is severe. And that's based off of that original Rudsky article from 2010, the American Society of Echo Right Heart Guidelines. But we're really hoping to reevaluate what those standard deviations are, because mild, moderate, severe don't actually correspond with 2 standard deviations, which is how the guideline suggests that we should be doing it right now. And especially if your mean PA pressure is 20 as the new cutoff and an RVSP is 35, those 2 things don't go together. I also noticed in that exercise study that we were defining an abnormal pulmonary vascular response as a delta change of your RVSP from rest to stress of 20 and or crossing an RVSP cutoff of 50. And we had a lot of patients that then underwent invasive right heart cath, and their RVSP cutoff would match what we saw in echo, but their mean PA wasn't crossing. And so there's this whole intermediary range. And what really needs to be done is simultaneous echo, exercise, and invasive right heart cath to determine what is actually abnormal by echo. And we're actively working on it.
Got it. That's great. And that also answers my question is, on echo, what are your ranges as far as defining mild, moderate, and severe? So thank you for answering that question. Let me check with Dr. Ashwath if she has any questions or comments.
No, I just wanted to thank Monica. That was a very comprehensive and complete review. That was very informative. Thank you very much for doing the talk for us, sparing time on this Saturday away from your family and doing this. I really appreciate this. So,
of course.
Yeah. This, again, I'd like to, at this time, take a moment to thank the rest of my planning committee who has put in a lot of effort in making this happen. This lecture series wouldn't have been possible without, the support of the planning committee, speakers like you or the, the audience joining us every Saturday. So thank you all very much. Enjoy the rest of your summer. Again, the recordings will be posted on the website. If there's any feedback, do let us know. And if you see us at any conferences or anywhere, do stop by and tell us hello. That would be nice to meet who is joining this session. So thank you.
Thank you, everyone, and enjoy your afternoon.